All right, if folks could take their seats, I think we're going to get started. All right, if folks could take a moment and take their seats, and I don't know if the mic is high enough. All right, there we go. We're going to get started. I want to welcome everybody to the Behavioral Health Medicaid Managed Care Kickoff Forums. This is, I believe, Gary and I's 9th one of these at this point. We've lost track at this point. We've been on a bit of a roadshow, primarily in the city, and we're really glad to be able to be here in Albany today. Before we get into introductions, I want to give a couple logistical updates and just some of the logistics. We are going to take a break today after the government presentations. Before we do Q&A, we're going to take a break today. Give people 10 minutes to go and use the restroom and do all those kinds of things. We haven't at some of the forums, but we've got a little extra time today, so we're absolutely going to take a break for folks. But if you need to take phone calls, take emails, take all those kinds of things, feel free to step outside and do that in the lobby, but please don't do that in here. We are doing something different today, which we have not done in any of these other forums. We are webcasting this event live, so if you could really kind of make extra effort to kind of keep the sound to a minimum as we go forward. We will take 2 specific spots for Q&A. We will make sure there is plenty of time for questions. We've gone at least half an hour, I think, in each one of the forums that we've done so far for questions. So after the break, we will have after the government presentations, we'll have about half an hour for Q&A there, and then another 15 minutes or so for Q&A at the end. So please hold your questions until the end of the government presentations, because what we've learned over the course of these forums is that people generally get many of their questions answered as we go forward. So I just want to be very, very clear on that, and then we'll have plenty of time for questions. We are going to ask folks when they do ask questions at the end to please come up to the 2 mics here so that the online folks can hear the questions and answers as well. We will also be having somebody taking notes during the Q&A portion, and all of the notes from all of these forums are being pulled together and will be condensed, and anything given by government today will be preliminary until it comes out in the official frequently asked questions, and that'll get posted on the Managed Care TAC website. It'll get posted on OMH and OASAS and DOH's websites as well, so that'll be out in a couple weeks. And actually the questions have varied across all of these forums. So before we get into introductions, I just want to welcome everybody here. There'll be a little flush as we move in, but the room will be relatively full today. I think we've officially sold out every one of these, so the chairs in the back will fill up as well. So with that, I want to just pass this on to Linda Kelly, who's going to give a couple words from DOH.
Thanks, Andy. Good morning, everybody. All right. Come on, good morning. This is going to be a long morning. I really want to welcome you. I'm Linda Kelly from the Department of Health, and I'm the department's project director for behavioral health transition. It's been really, really exciting. We're working really closely with our partners at New York City, with the Office of Alcoholism and Substance Abuse Services, with OMH, with stakeholders. It's really been really terrific. As the single state Medicaid agency, folks know Department of Health is the Medicaid agency. We've been working continuously with the Federal Centers for Medicare and Medicaid Services, CMS, on all of the Medicaid redesign team initiatives. So you'll hear, as our speakers talk today, you'll hear about FIDA a little bit. You might hear about managed long-term care, health home. Andy's going to talk about acronyms, about BIP states, and what I always like to say, if you've heard me speak, I like to say that's like a big piece of puzzle. All of those pieces really are going to fit together. We're really talking about the vision of healthcare reform, healthcare transformation, and all of this, when Gary later on talks about the principles, person-centered planning, care management for all, integrated healthcare, this is really what we're looking for across all of healthcare, not just our behavioral health initiative. So again, I'm going to keep it brief, although I love to talk in front of people, and I'm going to turn it over to our OASIS partner, and that's Rob Kent. Thank you.
Wow. Some empty seats over here, though. I don't know. Good morning. You got it. This is Oasis now. You got to do better than that. The Oasis providers could be louder than that. Come on. So, want to thank everybody for being here. This is, what number is this?
Eight or nine, I think.
8 or 9? It just all runs.
They run.
Yeah, they run together. There's more to come. This is a beginning, not an end. So While everything starts in April in New York City, we needed to get around to everybody in the state to get people updated, to give you a sense of Andrew and the group that's going to continue the effort to try to get you all prepared to move into Medicaid managed care. You know, I guess we've taken our time, that's for sure. But we were given the time, which is a good thing. You know, I've said we were given the time to put the thought in that was needed to do this. Speak for Oasis and OMH, our populations are different. The factors that matter to them sometimes are different than what matters on the physical health side. So it's been important that we think this through, do it smartly. We think we have a good approach. Charlie Neighbors, who's from CASA, who's the partners with MCTAC on this initiative, he said, you know, you're really practicing chaos theory. I said, what's that? He said, well, you start with the premise that you don't know where you'll end up. You have a decent idea, but you have the ability and willingness to change on the fly. And I know that's tough for me to say for you as a provider, but it has been that way. You know, for as many questions as we answer, there's probably 3 or 4 that get raised at the same time. So we understand that. We appreciate you guys, you know, bearing with us. We think we're doing it the right way. Who am I supposed to turn it over to, Gary?
You can turn it back to me, and
I'm going to turn it back over to Andrew then. Thank you.
All right, so before we bring Bob Myers up here to give a more global vision, I just want to introduce a couple other folks. First from OASS, we have Pat Lincourt and Ileana Melzer. And from OMH, we have Martha Schaefer, Gary Weiskopf, Donna Bradbury, and Tom Smith. And I'm sure we're leaving out a bunch of folks from the other government agencies as well, but just want to introduce those folks. And then I'm going to turn it over to Bob Myers, who's going to talk a little bit about OMH perspective and also kind of the global vision.
Thanks, Andy. I'm Bob Myers from the State Office of Mental Health, and I've been working closely with Linda and Rob and our other state partners on this design and now the implementation. So completely agree with everything they said about where we're going. I was asked to talk a little bit more in depth about today and how today links to the future. So, you know, what these provider readiness sessions are for are to start giving providers information to get ready. Not that you're not getting ready now. I know a lot of you are out there doing lots of things, and the fact that the FIDA is already out there, and many of you are being approached to be involved in networks. Many of you already have contracts with managed care plans. But what we're going to give you information today is about approaches to joining networks, connecting with managed care plans, billing in managed care environments, estimating cost, very important. In a fee-for-service or in a contract environment, a lot of you haven't done that as precisely as you'll need to do as you start to negotiate with plans. You have to make sure you get the adequate payment. And efficient. You have to be very efficient. I know that MCTAC, the close twin of MCTAC, has provided a lot of technical assistance around efficiency over the past several years, and that's been real helpful. Going to a managed care environment, you have to focus on that even more. You're also going to hear about some protections we've built in for providers for the first couple of years about government rates and being included in networks. You'll get the detail on that. The idea there is we wanted everybody that's, quote, a player now and is working with this population to have the opportunity to be engaged initially with some protections. But then after that, you're going to be on your own. The environment's going to be very different. It's going to be a competitive, quote, business environment. And what is our business? Our business is helping these populations manage their illness and recovery. So you got to remember that. That's the business. The business isn't just joining networks. So I wanted to talk a little bit about necessary and sufficient. As you hear things today, it's going to be necessary that you join a managed care plan. If you don't join a managed care plan, you're not going to get any business. It's going to be necessary they get referrals from the managed care plan. If you don't get referrals, you're not going to have any business. It's necessary that you join networks, that you join health homes, that you're part of the performing provider system conversation. Because if you look at the health department's vision for the future, after 5 years, 90% of the managed care payments are supposed to be done in alternative payment methodologies, value-based purchasing, for that, some of those of you that kind of start to understand that multifaceted concept. But the idea is that as these PPSs start to function and produce results, the managed care companies will be contracting with them with alternative payment methodologies, and they'll be stepping down payments to their network partners, in many cases through risk or performance contracting or other approaches to value-based purchasing, the idea that you're buying value, you're not buying units of service. So my message really is that listen today about how to get to the table, but your long-term survival is going to be really built on outcomes. What we're asking the managed care plans to do is include everybody initially, work with those providers to become more efficient and to focus your care plans more on outcomes, and then start to decide who's producing the outcomes and who's not, and then quote, it's an awful term, but pruning back the network to those providers that produce good results. So you'll hear a little bit about how to measure your outcomes, but one of the most important things is to start to focus on measuring your outcomes and on staff development, making sure your staff can produce quality results. So you need to think about evidence-based practices. You need to make sure you have adequate supervision built in, and you need to really track your staff not just on, quote, productivity, how many people could they see in a day to create a bill, but are they producing a result? Are they putting a good plan of care together? Are they showing progress on that plan of care? Are you able to measure symptom reduction? Are you able to measure recovery outcomes? Because a few years in the future, that's what we're going to be asking the plans to focus on, and they're going to look at you to whether they don't produce the result, they purchase the result and try to choose partners that produce the result. So you need to think about that. So right now we're moving about $1.5 billion of behavioral health dollars into managed care plans. About 1.2 of that is going to be in health and recovery plans, and another $300 million is going to be in the mainstream plans. Half of that is inpatient, detox admissions, and emergency room care. So we think that there's a significant opportunity to appropriately manage inpatient care to get better results, reduce length of stay where it's appropriate, not to take that money as savings, but to rotate it into first ambulatory care to increase clinic access and provider accountability, and then to fund recovery outcomes, the home and community-based services that we're talking about, or more PROS services or mobile care. So one thing you need to think about is, depending on where you are in the system, how could you contribute to keeping people out of the hospital? If you're an inpatient provider, it focuses more on the quality of the inpatient care, the quality of the work you do with the individual there, not on providing any care on Saturday and Sunday, but if somebody's in there, they're getting active treatment every day. And then the quality of the discharge plan and how you communicate with that, how you engage the care manager. If you're an outpatient provider, your accountability for first engagement is going to have to increase. It's not going to be acceptable that if somebody is referred to you, they just had an inpatient stay and they don't show up, you don't do anything about it. You're really going to have to be assertively engaging this population. In New York State, if you have an inpatient psychiatric Article 28 admission, you have a 20% chance of being readmitted within 30 days. I don't think any of us should be proud of that. And that's something we need to change if we're going to free up dollars to increase ambulatory care. And that responsibility is on the inpatient, but also especially on the ambulatory side about active engagement around discharge. If somebody doesn't show up for their second appointment, you're going to have to be assertive about it. You're going to have to work with the care manager around outreach. And if somebody is hospitalized, you're going to have to actively work with the individual. In terms of ambulatory accountability across the board, you're going to have to look at risk management and people that are disengaged and lost to care. And then another thing we're trying to accomplish, because the premium is an integrated premium, is that in New York City, it's $2,500 a month. Up here, depending on the area of the state, it goes from the low twos to $1,500 a month. But that's divided. I'll talk about the New York City premium. $450 of that $2,500 a month is pharmacy. So we're going to ask the plans to really focus on better pharmacy management. Then the remaining $2,000 plus, a little more than half of that is for physical health and a little less than half of it for behavioral health. So the folks you work with, a lot of them have chronic health conditions. But when you look at the numbers underneath that, they're actually spending more on the physical health side than the behavioral health side. And it's diabetes, it's asthma, it's hypertension, it's cardiovascular disease, it's undetected things like cancer. The population dies many years earlier than the rest of the population in the country. So as a behavioral health provider, you're going to have to talk about start to think about how you're going to be an integrated care partner. If you're doing care management, how you're going to do an integrated plan of care, and all the parts are going to have to work together. So that's really the vision for the future. When you're sitting there thinking about how you're going to become part of a network, how you're going to negotiate price, how you're going to get units of service, referrals from the managed care plans, start thinking about quality now, and then you'll do really well in the future. And when you do see the BHO1 data and you see that there's some real problems in the system on the inpatient side, on the handoffs, on the readmission rates, start thinking about where there's really opportunities for quality improvement right away. Thank you.
All right, thank you, Bob. So before we get started, I just want to kind of walk through the agenda really quickly, and then we'll turn it over to DOH. So we're done with welcome, so that part's done. A couple things in your folder. You have all the slides in your folder. We will also be sending those out both in a slide version and a PDF version after the forums are done. Obviously, you're not going to be able to read all the slides, especially when you get to the children's slide. They have the best graphics, but they're like really, really tiny. So we'll send them out and you can look at them, but if I'd given people one slide per page, you each would be taking home a ream of paper, so that didn't seem like a good idea. So we're going to start with DOH, going over kind of the landscape of managed care in New York as it is today, and then we're going to transition to OMH and OASS. We're going to give kind of the transition we're moving to, as well as other provider protections and those kinds of things. Then we're going to take a quick break, come back, ask about half an hour of questions, and then transition into the Managed Care Technical Assistance Center portion of the presentation, which we'll go through, and we will shoot to wrap up around 1:30-ish. So with that, I'm going to turn it over to, I've got all these names, Hope Goldharber and Alyssa Costa from DOH.
Hi, good morning. I'm Hope Goldhaber, and I'm with the Division of Health Plan Contracting and Oversight in the Office of Health Insurance Program in the New York State Department of Health. So anybody keep track of all that. My partner is Alyssa Costa, and we're going to tag team this a little bit. We thought this is really exciting to start on this transition, but we thought it would be a good idea to start with where we are right now, and that's this part. So we'll start today talking a little bit about where we are right now. There are some providers that I'm sure already have contracts with Medicaid managed care plans and are familiar with the mainstream program, but some providers are not or have had limited contact with the program. So we thought it would be a good idea to do a little overview and kind of talk about the framework that exists and how providers interplay with Medicaid managed care right now. We also have some information about who must enroll in plans, and what we will go into a little bit of detail about what we feel is like sort of the baseline of what all providers should know about working with plans. And this is really an introduction, and that's what today is really about. Okay. So I'm going to talk about what managed care is. We use that term a lot, and not everybody really knows what it means. We're talking about a general term that's used to describe any health insurance plan or system that coordinates care through a primary care practitioner or is otherwise structured to control quality, cost, and utilization. Now that three-pronged pathway is really important. And a lot of the things that we think about when we think managed care is actually seen in a lot of different insurance products. And this can cause confusion for providers that are trying to contract and deal with multiple types of insurance plans. So you'll see things like authorization requirements, capitation, referrals, preferred networks in many different types of insurance products. But today we're pretty much talking about a specific kind of insurance, which is just managed care plans or HMOs in New York State. I think there's a slide that I'm not seeing. But I'll turn it over to Alyssa, and she'll start getting into some details about the mainstream program.
So does this work?
The green arrow is forward,
Okay.
and the red arrow is back.
Okay. Hi, everyone. Good morning. My name is Alyssa Costa, and I'm in the same division as Hope in the Bureau of Program Implementation and Enrollment. So I'm going to talk more about specifically where managed care is in New York State with the Medicaid program. New York State currently contracts with managed care organizations, and and the managed care organizations pay providers to do that. So that means we pay a per member per month fee, and the managed care organizations manage the care and are responsible for ensuring that the enrollees get the care that they need. There are a lot of carve-outs that we've had in the past that are going into these plans now. Right now, we have over 4 million Medicaid recipients enrolled statewide as of July of this year. So most of the carve-out services will be covered by Medicaid managed care in 2015, and this is one of those large populations. It does work. Yay. When technology works. So the mainstream managed care plans that we talk about, those are your HMOs that we're most familiar with. There are private prepaid health service plans. One of the early carve-outs that went in were the HIV SNPs, the special needs plans. And this behavioral health stuff is very much in that, learned from that type of population of going in. And all the plans are qualified by the Department of Health. We're currently going through a very tedious process in order to qualify plans to provide these services. And then the plans, again, are responsible for assuring that enrollees have access to all the services in the Medicaid program. And so that's a number of things. They're entitled to all Medicaid covered benefits, which is a fairly comprehensive program and one of the most comprehensive, if not the comprehensive in the country. Plans can establish their own program, but we set the floor as the state and make sure that at least those basic needs that we've set under law are being met, law and regulation are being met. So there's a lot of different ways for them to go about that. The basic coverage, again, extremely comprehensive: inpatient hospital services, physician and nurse practitioner services, lab services, radiology, all the things that we think of when it comes to a comprehensive plan. But there's a lot of other services as well, and we've recently transitioned a number of them under the MRT program to make sure that they have that it's even more comprehensive. So there's orthodontics and personal care services and all those things. And the home and community-based services are going to be another one of those new services coming in that they're going to be talking about later today. So the basic package is already very comprehensive and in place. Folks in Medicaid managed care already get inpatient mental health services. They already get outpatient mental health services, inpatient substance use disorder services, and outpatient substance use disorder services. This new population coming in needs more intensive care, and so that's why we're expanding the benefit package this way. And so the behavioral health managed care vision is actually really exciting. You hear a lot of talk about integrated care and fully integrated care working together, and it really is. It's a matter of dealing with those comorbidities and making sure that that enrollees and patients are getting the comprehensive care that they need, and that there's communication. That's the part of the managed care piece that we're always talking about. And working with OASAS and OMH and all the folks, it's really been amazing the dedication that they have to this vision of making sure that folks are not going to fall through the cracks and get the services that they need, and that the providers and the network are there for them when they need it. So the next step is, well, how does someone get enrolled in a managed care plan? We've got folks that are not in managed care. They're either already in Medicaid and going fee for service, or they're going to have to enroll in a managed care plan. So what's that going to mean for them? So there's a number of avenues for folks to get into managed care plans. Right now, just about everyone is mandatory or going to be mandatory for being in managed care, and that's what this is all about, getting them into those programs. So typically, folks can go to the online marketplace where we've had the exchange to check eligibility and see if they're eligible, and then get enrolled that way. They can go directly to the managed care plan if they're already a they're already enrolled in Medicaid, they can contact CDPHP or whoever that provider is. There are certified application specialists and navigators. Typically, those are grant funded through the Affordable Care Act. And they can assist folks on the exchange or in person. They can go through the 1-800 number statewide and get assistance that way, or go through their local social services district offices. And it doesn't matter where you are, all these avenues for enrollment are available. And in order to make sure that folks are understanding the process, there is education for enrollment and application assistance. And New York State contracts with an enrollment broker called Maximus. You might hear about them. They are folks who help anybody who calls them, and some of them are on site to enroll in to see if they're eligible and enroll them in plans. And they're required to educate them about what each plan has, how their providers are worked into those networks. Is your primary care physician in the network? Is your behavioral health provider in the network? So that they can make informed decisions about what plan they're going to enroll in. So all that information is required that they're educated on through the process. And so, again, most Medicaid eligible individuals are required to enroll in a Medicaid managed care plan. There are exemptions and exclusions, and this has been an exempt and excluded population. So exempt individuals will then be able to choose to enroll in a plan or remain in fee-for-service Medicaid. It's not, there's different avenues of getting there. And so there's different folks who are exempt still, such as Native Americans and persons with chronic medical conditions and folks like that. So how you'd obtain an exemption is the system right now is identifying those folks based on their current usage in Medicaid. And there's a waiver program for the developmentally disabled individuals right now. And there are some exemptions where applications are necessary. And that has to do with 6-month chronic medical conditions, long-term residential places, and Native Americans again. So then the exclusions for Medicaid managed care are, might help if I flip that properly. Sorry. Oh, thank you. So the exclusions are dually eligible individuals, folks who have comprehensive third-party health insurance, individuals residing in nursing homes or hospice programs, individuals who are eligible for TB services only. Those folks are still excluded from managed care. And so then there's a coverage process. We're always concerned about folks sort of falling through the cracks, right? So I have to enroll in a managed care plan. I've just qualified for Medicaid, and I have to enroll in a managed care plan, but my managed care plan may not enroll me until the 1st of the month, but it's maybe the 15th of the month that I found out I'm enrolled. As soon as you're deemed eligible for Medicaid, you're enrolled in fee-for-service Medicaid, and you can already start getting those services. And that's the importance of making sure folks don't fall through the cracks. So the enrollment is processed prospectively, and eligibility begins in the month of the application. And in some cases, it can start up to 3 months prior, depending on the situation. And then Medicaid, again, they're covered by fee-for-service until they are enrolled in a plan. And so an example of that, just to sort of show what the process is, say someone submits a Medicaid application on May 12th. The person is eligible to receive fee-for-service on the 1st of that month, so backdated to May 1st. And then the consumer takes their time, figures it out. They don't select a plan until June 12th, and their effective date of enrollment in a Medicaid managed care health plan starts on July 1st. Until July 1st, they're still receiving fee-for-service Medicaid. And so they'll continue to receive their services. So that's sort of the picture of how things are currently set up. And again, lots of conversations happening between all the agencies and the folks to make sure that this happens in the proper order and ensure that folks get the services they need. So we're going to switch back off to Hope.
Like a bad penny, here I am. So I want to just talk a little bit about working with managed care plans and what are some of the key things that we think all providers need to know. And I'm starting with Medicaid managed care consumer rights. What exists right now is a structure in law, both federal law and state law, about how HMOs need to operate. And all of those laws that that HMOs need to abide by are brought into the Medicaid program. So all those laws still apply. And then we have additional protections that are put in for Medicaid recipients. So this slide has a lot of information on it, but it has certain basic consumer rights that as a provider you want to be familiar with, because often a provider is the advocate for the consumer. So it's right to information about the plans, access to needed care, right to out-of-network care if a plan doesn't have an appropriate provider that can meet the enrollee's needs, right to complain, grieve, or appeal, and the plan is prohibited from taking any kind of retaliatory action if you file a complaint or a grievance. And then for Medicaid managed care, you see there's some expanded transitional care provisions. The right to a fair hearing exists in Medicaid, and reasonable assistance in just and exercising those rights. Sorry, I have a little bit of a cold today, so I'm struggling. Moving on, though, I do want to talk about specific what providers, what's really good to know if you're a provider working with a managed care plan. This whole process is here as a kickoff. So what I'm providing you today is just sort of the structure that providers and plans operate within when we're talking about law, regulation, and what's in the contract. This is your baseline. This is your framework. And then as we move later on in the program to the behavioral health transition, you will see how they've taken that framework and then added to it. And there's a lot of pieces where they have increased provider protections, where they've increased the standards that the plans have to meet. And so you want to watch for that as we go through the description of the transition. But for now, let's just get back to the baseline. So I will be going through these current requirements. When it talks about the patient-provider relationship, all of these things are in public health law. The provider has the right to discuss all treatment options with the member, whether or not they think the plan is going to cover it. The provider can assist the enrollee in filing grievances. There's no penalty or retaliation, as I mentioned before. And the provider contract itself cannot be terminated solely because the provider advocated for an enrollee or took advantage of the grievance processes. When it comes to provider contracting, there's also statutes around that. A lot of providers don't realize this, but every provider contract or template is actually approved by the Department of Health as to form, just to ensure that all of the rules are being complied with. So here's some of the pieces that you see. We do review the risk-sharing arrangements. Plans are not permitted to downstream all risk. They have to retain some of that risk. The contract itself has to provide the payment methodology, and it also has to discuss dispute resolution processes. And there's a hearing process if the plan seeks to terminate a provider. There's also a 90-day opt-out. You should be receiving a 90-day notice if there's an adverse change to the contract, to the fiscal arrangements of the contract. And that's important for the provider to understand if they want to continue with that contract or if they want to end the contract at that point in time. Rates are negotiated between the provider and the plan. However, as we move through the MRTs, anybody who's touched any of these MRTs, we do put provisions in place to kind of hold the rates in the fee-for-service. Like a lot of times we'll say, okay, plans have to hold the fee-for-service rate for a year. Or whatever the transition policy is, in order to give providers a chance to adjust to working with plans and working in that environment. And I'm pretty sure that's going to be part of the behavioral health transition as well, to sort of hold those rates steady while you figure out how to do all these other pieces. When we talk about network requirements, in the law, in public health law, if you want to join a plan, that plan has to provide you with the application and the requirements to be a provider. They don't have to contract with every willing provider, but they do have to explain to you what the rules are and how to apply. If you do apply, there's a certain time frame in which the plans have to respond. Also, the credentialing qualifications have to be developed with input from health professionals, and the performance reviews have to be done in such a way that you understand what they are and what performance bar you're going to be held to. And there has to be a process for you to explain if you have a case mix that might shift your performance bar, and the plan should be taking your case mix into consideration. Everybody's really concerned about payment, right? I mean, well, we could just skip this slide. You don't want to know anything about it, right? There are a lot of pieces in the prompt pay law. When I talk about prompt pay law, I'm actually talking about New York State insurance law now. Excuse me just a second. I'm not going to go through this in detail, but you can see from the slide, there's a lot of pieces in prompt pay that talk about ensuring that clean claims are paid on time. And I know the Department of Financial Services spends a lot of time working with providers and plans to ensure that these claims are being paid on time. Coding dispute resolution, there is a little bit in law about that, but I think we're building in some more protections about codes in the transition as well. There's a requirement that if plans are going to make a recoupment, they have to provide 30-day notice. There's some pieces in other laws, and when I talk about non-par inpatient ER and ER services are paid at the fee-for-service rate, this is when you're non-par, when you're not a contract provider. There's certain services that are automatically paid at the fee-for-service rate. It kind of takes the negotiation equation out of the mix. And I mentioned before that there are some transitional care pieces for new enrollees. Everybody talks a lot about service authorizations, and there is a very strong structure in state law and public health law about how the plans need to do prior authorizations and concurrent reviews and retrospective authorizations and the time frames they need to make those decisions in, and the notices that they have to issue are actually quite detailed in what needs to be sent to the enrollee and the provider when there's an adverse determination made. But one of the things I want to bring home, especially around behavioral health, is that the plans may not be requiring prior authorization for services. The plans are going to be seeking other ways to manage these services. Remember I talked about those three prongs, controlling quality, cost, and utilization. Prior authorization is only one tool to effect those changes and to manage that care. The plans are now going to be a partnership in care management. Prior authorization may not be what they put in place for behavioral health services. Every plan is free to structure their authorizations the way they feel is appropriate for their enrolled population. You as a provider need to know what your plan is actually requiring authorization for. You need to know your contract and your plan's policies. That is the best way for you to understand what the systems are, when authorization is required, and what to do if there's a disagreement. I'm getting ahead of myself. So these are some timeframes that I mentioned that the plans have to comply with. The timeframes for Medicaid managed care are actually in Appendix F, as in Frank, of the Medicaid model contract. If you've never seen the Medicaid managed care model contract, it is on the Department of Health website. That contract will be adjusted to include all of the new behavioral health transition pieces that are coming in. But for now, you could go ahead and look at Appendix F and get the idea of what these timeframes are that plans should be responding in. And certainly, if you're already a provider with a plan, it's something that I'm hoping this is a good overview for you and a reminder that those timeframes exist. I have to say that in my bureau we handle the complaint unit, and one of the frequent complaints that we get from providers is that they make a request to the plan and the plan doesn't seem to respond to them for a long time. And I have to say that when we investigate it, that does not seem to be the case. What happens is when we move to the care management model where there's patient-centered care and the plan is a partner on the care management team, there's a lot of discussions going back and forth about, do we do this service, do we do this service, what's the proposed plan of care? And what happens sometimes is that the authorization process and that care management, that team discussion start mushing together and blending a little bit. And providers and enrollees sometimes get confused about where the prior authorization piece for the plan starts. And conversations happen where the plan might see the first blush of the care plan and be thinking, well, I'm not really seeing the justification for this or the clinical need for this. Let's talk about this some more. And the provider thinks, oh, the plan's denying it, but I didn't get a notice and I don't know what they're denying and I'm not sure what's going on, and now the enrollee's in a panic because they think something's being denied. That's not necessarily the case. As a provider working with the plan is your partner in the team. It is very important that everybody understands when the authorization process is starting and when the plan is actually doing their clinical review of the care plan and when the plan is expected to issue a denial. And that will help you move through any potential disagreements. So, sometimes even with care planning, there may be an adverse determination issued. This is a notice of action. And as I mentioned, there's a lot of detail in the notice of actions. They have to provide a clinical rationale. They have to provide a detailed reason for the denial, if it's administrative, if it's a benefit denial. The enrollees have the right to appeal. Providers also have rights to appeal on their own behalf. A lot of the times that procedure for providers is only going to be found in the plan's provider manual and policies and procedures. So, you need to understand the difference between what are enrollee rights and what are provider rights, depending on a situation. So what happens if there is a disagreement? So possible next step are discussing the alternative service options with the care manager, request the specific clinical criteria under review. I cannot tell you the number of times that we've seen things go back and forth 10 times because the provider doesn't understand what criteria is not being met. More information is always good. Ask for it. You can file an appeal with the plan. When you do that, it's always important to document what you're appealing exactly. And of course, if there are administrative issues and you feel that the plan is not cooperating or you feel like you're hitting a wall, we do have a complaint process at the Department of Health, and we would certainly be willing to help work out somewhere where there's things that don't seem to be working just quite right. When we talk about appeals, enrollees have at least 60 business days to file an appeal. There are time frames in which that plan appeal has to be responded to. And the same thing for providers. You should be familiar with your plan's procedures. Did I say that enough times? Just anybody counting how many times I said that? Okay. There's also external appeal. An external appeal is one of those things that's in public health law, that's in insurance law also, that is now brought into the Medicaid managed care program. The appeal is decided by a clinical reviewer that's independent, that does not work for the state or the plan. It only applies when the services are being denied because of medical necessity. Enrollees have 4 months to file, but providers only have 60 days to file. So that's, again, another pathway for resolution that you want to be aware of. And as I mentioned before, the department does take complaints. This is the 800 number. When filing as a provider, make sure you identify the plan and the enrollee. I want to emphasize that the Department of Health can only take complaints for HMOs. If you have other insurance products or other issues that are outside our jurisdiction, we will refer your complaint to our sister agencies and try to assist you any way we can. So allow me to just sort of wrap up a little bit. One of the things that I think is very important for providers to do is verify your client's eligibility. One of the things I know is that if you have somebody who's on SSI, their Medicaid eligibility might be very stable. It doesn't change from month to month. And you're kind of used to once somebody being in the Medicaid program, they're just covered by Medicaid ad infinitum. However, even though their Medicaid eligibility might not change, I will tell you that their plan will change. So it is very important. We always recommend that providers check eligibility, especially if you're in a situation where you're seeing a client often during the month. You might not realize, maybe not every time they come into the office, but certainly at the beginning of the month and sometime in the middle of the month, maybe around the 15th, check eligibility. Next month, they might be in a different plan, and now you want to make sure you're working with the right plan when you're seeking payment. I hit the button too soon. Know your provider contract. Is that like number 5 now? Know your provider contract and the policies and procedures. Obtain authorizations as required. Provide services according to the approved care plan. If something changes and your patient now needs something different, make sure you go back to that care plan and adjust it so that everything is authorized the way it needs to be. The plans are part of the patient-centered planning team. It's always important to submit full information to support what you're doing. Avoid just saying, I need authorization for per diem, or something that's sort of like a buzzword or a code word for providers may not mean the same thing to a plan. Make sure you're asking for the specific services you need authorization for. So these are things that I have just, in my experience, are issues that providers have run into with the Medicaid managed care program as it is now. And I'm hoping that this is sort of like a springboard for where we're moving now going forward for everyone. It's, sort of like now we're all on the same page here, and now we're ready to move forward. Now we're looking for this behavioral health transition and all the new pieces that are going to be added to this framework. And I'm going to pass it on to Gary. Gary and Tom Smith. Thank you, everyone. That's you. Thank you.
Which way is forward? Next, okay. So hi, I'm Gary Weisskopf. I'm the OMH Associate Commissioner for Managed Care, and this is Dr. Tom Smith, who's our Medical Director. And we're going to start by talking a little bit about what we're doing with regard to behavioral health transition and why. But before we do that, I think it would be very helpful to us, at least, to get a sense of who's in the room. So if you're a mental health outpatient provider, please raise your hand. All right, good. Mental health inpatient? Few, okay. Substance use outpatient? Substance use inpatient? Kids provider? Wow, okay. Kids provider who only serves kids? Few. So it's quite a mix in the room. A couple more questions. How many of you would consider yourself administrators in your program? Clinicians? All right, and finance people. It's really interesting because we've done, I guess, 9 of these, and the mix is always really different in the rooms, and the mix between admin and finance and clinical. And as Ileana likes to say in a lot of our presentations, this is really a team effort. Everything we're going to be talking about involves admin, clinical, and finance. And everybody needs to understand what we're about to talk about because it is such a significant transition for the way that you do business. And each one of you, it will be different for. Because the mix of people who are being seen in your programs will be different. Your SSI versus your, TANFs, people who are in managed care. Everything we're going to be talking about here are Medicaid managed care eligible individuals who are 21 and older. That means they're not duals in general. Very few duals will be in Medicaid managed care. We're not talking about the FIDA plans. We're not talking about those few exceptions. Spend downs, we're not talking about spend downs or any of the other people who are exempt. Okay, so everything we're going to be talking about is people 21 and older, Medicaid managed care eligible. You need to understand what percentage of your mix those people account for. All right, so I guess I just turned that off. Let's see, here we go. We're going to talk a little bit about, I can't read any of that, so I'm just going to wing it. My glasses broke, not that you guys care, but so hopefully I remember this from the other 9. So anyway, what are we doing in managed care? What we're doing is a pretty significant transition from, particularly for people who are SSI, who had all of their behavior or mental health services carved out. But we have a range of individuals who had either some substance use, some mental health, services carved out, and all of those services are moving into managed care. And in fact, even for people who got their clinic and inpatient services in managed care, all the other mental health specialty services and some of the substance use services have been carved out. So as part of the Medicaid redesign team, the state was taking a look at the whole Medicaid program in general, and Linda had alluded to this a little bit earlier and said, all right, well, our Medicaid costs, they've really been going crazy. They're really growing and growing and growing, and they're squeezing out pretty much any other ability to pay for education or parks or transportation. And when we look at the overall results of our medical healthcare spending on the Medicaid side, it's not like we're number one in the nation. We don't have the best outcomes for individuals. We're spending the most money, but we're not getting the best outcomes. And one of the things Tom's going to show us shortly is just some data that we actually have on what happens to individuals on the fee-for-service side going in and out of inpatient. But when you take a look at it, you'll see that we're really in the middle of the pack. We're spending a lot of money. We need to really change the way Medicaid works, and we need to really provide some serious care management on both the physical and the behavioral health side for individuals, and we need to bend the cost curve. So originally the idea was, okay, we're going to put everybody in managed care. But as Rob also talked about early on, there was a lot of concern that we not just rush right into managed care. In many states where behavioral health services were moved into managed care, there were a lot of problems. Providers went out of business, money disappeared from the system, people lost access to care. So in New York, we said, well, we're going to figure out how this should be done and how do we do it right. So the state created a work group under the Medicaid redesign team plan. So is anyone familiar with the MRT, the Medicaid redesign team of New York State? Could you just raise your hand, get a feel for it? Pretty good number of people here are. Well, the Medicaid redesign team, which is made up of hospitals and insurance companies and providers and consumers and a whole range of other stakeholders, they created this work group, which was also made up of behavioral health providers, behavioral health consumers, insurance companies, family members, consumers, and they got together and they spent a pretty good amount of time and they said, well, how should we move into managed care? How should behavioral health services make that transition? What kinds of protections should we put into place? And you can see, I think there's a link there that gives on the slide that will show you how you can get more information. And that report, which, let me see if I can do this right, that report, which was adopted by the Medicaid redesign team, has really guided our transition into managed care. And there's a link on the bottom of this slide that will take you to that report. And if you haven't had time to look at it, I really advise you to look at it, because there's not only is it good information and really thoughtful, but they put together, as I said, these principles. And I'm going to talk a little bit about what these principles are and how they're guiding us in our development. So first of all, person-centered planning. We talked about that a little bit, but the concept is pretty straightforward, that plans of care should be really revolve around what the individual's needs are. Integration of behavioral and physical health. Bob talked a bit, and you may not have caught it, about how much of the premium for people in health and recovery plans, that's the specialty managed care plan that we're putting together, and I'm going to talk more about it afterwards, for people who are high needs and meet a number of risk factors. That health and recovery premium, a little bit more than half of it is physical health. So when you look at the breakout, there's a huge amount of pharmacy, huge amount of physical health, and a large amount of behavioral health services for individuals who are covered. We have to integrate their care, or else what's going to happen and what will continue to happen is that people's physical health needs will not be addressed, and often it's because their behavioral health needs are not addressed. Interesting study done by the health department that looked at something called potentially preventable readmissions. People familiar with that concept? You could be kept out of the hospital if you were treated adequately in the community. And they looked at the data and they found that 2/3 of the potentially preventable readmissions were for people who had behavioral health conditions. So they had behavioral health conditions, but of those readmissions, for the 2/3 of the people who had a behavioral health condition, 2/3 of their readmissions were on the physical health side. So they're going in for physical health reasons, they have behavioral health conditions, and they're not getting adequately treated in the community. There's a clear overlap and intersection between physical and behavioral health problems that need to be addressed. We needed to ensure that there were comprehensive networks. We're going to talk a little bit about those protections that we put in place to ensure that there are networks, and I think Rob will be talking about that later. We needed to tie payment to outcomes, so the state is looking at how do we define outcomes for behavioral health. There are something called HEDIS measures. Anyone familiar with HEDIS measures? All right, a few of you. That's how the Department of Health measures the managed care plans and how well they're doing. Well, we use something called QAR, which is the New York State's version, and they have some additional measures within that, and we're looking to add more behavioral health measures to QAR. We're also going to be continuing the measures we did in something called BHO1, which was an initiative that we rolled out while we were doing the planning to get into the managed care rollout. And in BHO1, we hired 5 regional behavioral health organizations. In New York City, it was Optum. Around here, it was Community Care. We had Magellan. We had the New York State, what was it, NYCCP, and on Long Island, it was Long Island Behavioral Health, which was a agreement between Value Option and North Shore Long Island Jewish to do it together. And they were asked to monitor fee-for-service admissions. So let's look at people who are going into the hospital. Let's monitor what they're getting in terms of plans of care, discharge plans. Are they getting hooked up with the community? What is actually happening with them? And Tom's going to talk in a few minutes about what we learned from that initiative. But one of the key things was that we needed to really watch what was going on with regard to networks, integrated care, and to make sure that the spending on services was really following the needs of the people. And so part of what we're going to get to in a second, you're going to see some of that data, is really guiding why integrated care and following the needs of the individual and person-centered planning is really critical. And we learned a lot from the BHOs that we're really putting into this. We're also going to be tracking the spend. One of the things that we heard from everybody pretty much is that we have to make sure that money continues to remain in the behavioral health system. So we have something called the Medicaid medical loss ratio. Has anybody heard of a medical loss ratio? A few of you. Okay, this is also a really important concept. In the Affordable Care Act, I think you're probably familiar with the Affordable Care Act, Obamacare, right? I imagine most of you are. For health exchange plans, the federal government requires a medical loss ratio for those plans. And that's saying that ultimately 85 cents of every dollar has to be spent on care, and if the plans don't spend it, they have to return it to the premium payer. Well, Medicaid doesn't have a medical loss ratio, although historically most of the plans have spent over 90% of the premiums on care. But what we're putting into place is a medical loss ratio on the health and recovery plan side that will require, in New York City, 89% of every dollar has to be spent on care. In the rest of the state, it might be a little bit different because the premiums are different, but the concept is there. And in the health and recovery plan, the HARP, it'll be an integrated medical loss ratio. We will look at the physical and behavioral health spend for those individuals because every one of those individuals is a high-need behavioral health individual to begin with, and we're looking at the care that those people need. In the mainstream plans, we're going to have a medical loss ratio that's just on behavioral health, and we're working on the details of that now and how we would calculate it. But the idea is to ensure that the money is tied to people with behavioral health needs. If the money isn't spent, the state will take that money back. And we've also committed to reinvesting that money back for the needs of people with behavioral health. So it won't be taken and moved into any other location. And finally, we said that the MRT work group said that children and families, their needs need to be considered separately. So there was a separate work group set up for children and families. And that work group is now on a separate track, and they're looking to roll out managed care for children approximately a year after we go live, and we'll go over those dates shortly. So again, a separate children's plan, separate children's implementation. Everything you're about to see is focused on adults 21 and older until we get to Donna's presentation about kids. They have to be Medicaid managed care eligible, okay? And they have to be enrolled in a managed care plan. Oh, I keep doing the same thing. All right, so Tom is going to talk just a little bit about some of the findings from BHO1.
Okay. Hi, everybody. So Gary touched on BHO1, and you all probably remember it was 2012 and 2013 for 2 consecutive calendar years. We had the specialty behavioral health organizations review all behavioral health admissions within the fee-for-service program statewide. So Community Care was the BHO in the Hudson River region, Magellan in Central, NYCCP, Western. Many of you are probably familiar and still remember. And Kelly from Community Care is still here. John from NYCCP and CCSI is here. What we wanted to do was bring in the specialty plans so that the fee-for-service providers could start to get a feel for working with the managed care company, what it meant, what it involved. And we also wanted to get a sense of what are some sort of baseline measures of inpatient provider discharge planning activities and engagement issues and care coordination issues for this population. We thought that information would really inform the development of the fully capitated plans that we're going to roll out in the next year. So just a little bit of data. Here are some data for the adult mental health discharges from calendar year 2012. And we have 3 sets of measures here. On the far left is the 30-day readmission rate. Bob talked about that. Gary's talked about that. The data are broken out for New York City versus rest of state. We broke it out a lot of different ways. We thought this would be best. The readmission rates, as Bob and Gary have talked about, are 20% within 30 days for the adult mental health population. Again, a little bit higher in New York City, but still 20% for rest of state. That middle set of bars there are the our version of the HEDIS measures. Gary talked about that. You know, HEDIS are measures that are endorsed to evaluate managed care plan performance. And so there's not a lot of good measures for behavioral health performance, although there's more coming. We could have a whole nother talk about performance measurement. But these are rates of individuals coming out of inpatient mental health units. How often do people connect with an outpatient provider within 7 days? And we saw, again, for New York City in the mid-30s, for rest of state, a little over 40%. And then that third set of columns there on the far right is a measure we created that has to do with engagement in care. It's one thing to know who shows up for an aftercare appointment, but we want to really learn more about who stays or remains in care and really does establish continuity. So we're measuring things like 2 or more outpatient mental health visits within 30 days of discharge. And again, those rates there were low. A little over 30% in the city, and again, 40% in rest of state. So over half of people discharged from from a fee-for-service mental health inpatient admission do not connect with aftercare. So pretty striking numbers there. Here's the same data for the SUD discharges. So these are people, again, coming out of detox or rehab inpatient programs. Very similar numbers. For the readmission rate, we have a 45-day readmission rate here. For New York City, much higher. The rest of state, again, almost 20%. How many people connect with a lower level the substance use program within 14 days of discharge? Very similar, a little over 40% for upstate. And then the engagement measure, how many people had 3 or more visits within 30 days of discharge with an outpatient provider? Still 35%. So major opportunities here. We have well over half of the people coming out of inpatient care that do not connect and engage with aftercare services. So major focus for the phase 2 and the capitated plans. The last slide I'll show has to do, again, with the integrated care, integrated physical health, behavioral health care. We had the managed care plans, the BHOs, inquire for each admission whether the person had an active physical health problem. So again, these are admissions to detox, rehab, or inpatient psych units. We know that this population, the fee-for-service, SMI, serious SUD population, we know that rates of comorbid physical health problems are high. Anywhere between half to 3/4 of people have at least one physical health condition. But that's not the question we asked. The question we asked here is for someone who's admitted in a detox, rehab, or psych unit, does this person have a physical health condition that is active and needs management as part of this episode of care? So it's one thing to say, well, you have diabetes, it's stable. When you get out of detox, follow up with your primary care doctor and continue to manage your diabetes, versus saying you have diabetes and it's not stable, you really do need to have your medications adjusted and monitored. It's not severe enough that the person has to be transferred to an emergency room for a diabetic crisis of some sort, but it does need to be managed. Your blood pressure, your hypertension, your blood pressure is high. It's not at a critical level, but your blood pressure pills really should be evaluated and managed. So that's the question we asked. How many people really have an active physical health condition requiring management at this point in time. And the numbers came out about 36%. And we asked the plans, there's not a lot of good data on this nationally, we asked the plans what their experience was nationally, and they all said about 40%. They figured about 40% of all behavioral health admissions do need some active management of their physical health conditions while they're in the hospital. So then we asked that question, okay, of those 36%, how many had some evidence of coordination for physical health care? And what we looked at is whether they had an appointment scheduled with a physical health provider as part of their aftercare plan. It was an easy thing to measure. We had the claims data, we could look at that. What we found is that very few did. It was only 18%, so under 20% of people with an active physical health condition actually had evidence of care coordination and planning related to that condition. So again, major opportunities for us to do better with coordinating services as we roll out these capitated plans. And I'll stop with that for phase one. Oh, I'm sorry, I forgot about this slide. We added a slide. For many of you might know, we developed and tested about 36 measures, performance measures at the provider level for BHO phase one. And we created the BHO portal. It's a website through the OMH website you can get to called the BHO portal. And it has these measures, readmission rates, length of stay, a lot of these engagement measures, how many people had an appointment within 7 days or 2 appointments, how many people filled a prescription for a psychotropic medication after discharge, how many filled 2. We played around and developed over 30 measures. We posted them throughout 2012 and 2013. We posted them, but at the regional level. So it's for Central Region, Western Region, the Hudson River region. What we've done just a couple of weeks ago, actually, is we created some archive reports and posted them up there that have the data at the provider level. It's only for the mental health discharges, psych discharges. We didn't do it for the SUD providers. There's a lot of questions. Given the higher bar for confidentiality for SUD services, there's we don't really trust our data in terms of knowing who followed up and who didn't, according to claims and provider reports. But for the mental health providers, so for those of you who work or run a psych unit, you can now look and see the data for your program and for all other programs compared to the regional and state averages for 4 years. There's a report for 2010, 2011, 2012, and 2013 that shows your fee-for-service psych readmission rates, engagement rates, aftercare connection rates, prescription fill rates. We just put those archive reports up about 2 weeks ago. Should be very helpful for those of you, planning for this phase 2 implementation or planning for your DSRIP projects, working with your health homes. So please look into that. I think Bob's going to say a few words.
Thanks, Tom. I just wanted to make some editorial comments here. You have these slides. I'd really look at them because it's really disturbing what it's saying. And it's fee-for-service behavior is what it is. If somebody appears before you, you take care of them when they're before you, and if they don't appear before you, you don't know what's going on, and it's not your problem. So in the environment we're going into, it's going to be very different. Whether you're thinking about managed care, whether you're thinking about a performing provider system, inpatient psych just doesn't treat inpatient psych. You do a physical. If you see somebody has untreated diabetes or hypertension and you don't connect them to care, they're going to be admitted 2 weeks later because their diabetes is through the roof, and eventually, if it's not treated, they're going to have amputations. On the behavioral health side, if you don't engage people that don't show up after they come in an inpatient, the managed care plans are going to start tracking which outpatient providers are able to keep people in the community, and if you're not, you're going to be pruned. So I think you really need to look at this and figure out it's a system of care. Both the networks the plans are putting together and the networks the performing provider systems are putting together, and moving to value-based purchasing. Your reimbursement is going to be based on results, not on encounters. And if a performing provider system network doesn't address the whole person, no matter where they appear in the system, if a problem is identified, that provider system is not going to get their payment in the future. Starting in year 3, the payments are based on outcomes. If you're in a managed care network and you're a player that's not producing the results, and the plan's having to spend a whole bunch of money on inpatient when they really want to focus on recovery, you're not going to be part of that team for long. So I just wanted to say, just look at this data and think about how your organization should be behaving differently. It's like, going from horse and buggy to cars or going from typewriters to computers. You don't want to like hang on to the past and be left behind.
I will just say that I think I bought one of the last typewriters that anybody could buy at a really good deal. Right, it wasn't that long ago. Yeah, so it's a pretty good analogy. All right. So what is it we're doing? And I think this is where people might get a little bit confused. So we're going to try and be really clear about how we're rolling the behavioral health services into managed care. And essentially there are two ways. And the first thing is that if you're what's called a mainstream managed care plan, we're not talking about a managed long-term care plan, we're not talking about a FIDA, we're talking about a mainstream managed care plan, and you serve the Medicaid population, all of the state plan Medicaid services are moving in. So what's a state plan service? I'm going to jump ahead a little bit here. So can people see this slide? These are the state plan services. In Medicaid, there are mandatory services and optional services, and a state can choose to have a lot of optional services, and pretty much all the behavioral health services outside of inpatient would be optional. So our state plan calls for all of these services. We have federal approval to be able to provide these services. So you can see it's inpatient, it's clinic, and PROS, ACT, IPRT. I'm not going to read them all. It's the SUD services, opioid treatment. So every one of those services will be moving into a managed care plan. However, they're not just moving into the managed care plan. All the plans have to qualify, even if they already offer some of these services to some populations. So if you're a managed care plan that offers clinic and inpatient on the mental health side and whatever substance use services happen to be for whatever populations that you serve that are currently in your plan, and I know there's a mix and it varies by people, and Oasis can talk more about that, you still must be qualified, okay? And those qualification requirements sit in a request for qualification that anybody can go and look at on the OMH, Oasis, or DOH websites. There's links. We'll probably be tweaking that request for qualification a little bit for the rest of the state, but not so significantly that it changes what it is that you're looking at if you go look at it. And it's important because Section 3 of that request for qualification lays out what our vision and our requirements and our expectations are. And Section 4 lays out the questions that we're asking the plans, that where they're going to be justifying how they're qualified to deliver these services. And I'm not saying that you should spend your Saturday, reading this word for word, but probably skimming it and getting a picture of what it is they're being asked to do is important, because they're going to turn around and ask you to help them meet those objectives. And understanding that is important. So again, every plan must qualify, okay? So they're going to qualify, the state plan services will move in, and they will be responsible for approving services for any of providers who deliver those services that are in their network. Additionally, we're creating these health and recovery plans for high needs individuals, people who have risk factors. And all those risk factors are laid out in the RFQ, the risk for qualifications, and our waiver request to the federal government, because we need a waiver approval in order to bring these services into managed care. Remember, almost everybody who's going to get these services are already in managed care, Medicaid managed care. So the health and recovery plan could be people who have used inpatient services, people who use ACT, PROS, detox. And the way that the state is going to do this is we're going to run a Medicaid report and identify who these individuals are. We're going to tell the plans who these individuals are. We're going to passively enroll individuals into a health and recovery plan if the plan they're in is qualified to have a health and recovery plan. So let's talk about New York City, because that's where we're doing this RFQ process right now. And in New York City, there are 10 plans, mainstream plans that serve the city. 7 mainstream plans also apply to be health and recovery plans. That represents 80% of this health and recovery heart population. So 8 out of 10 people will be in a plan, assuming that they're qualified to become a health and recovery plan. 8 out of 10 people who are HARP eligible are in those plans. The state will identify those people through a data run. Those people will be what's called passively enrolled, so they'll be moved electronically into a HARP. The state's enrollment broker that DOH talked about earlier will send that person a letter telling them that you have been passively enrolled, you have some choices, you can do nothing within 90 days and you will stay in the HARP. You can choose to move to a different HARP, or you can stay in the mainstream plan because it's optional, okay? This is really important because a lot of the people that you serve may come to you and say, I got this letter in the mail, says I'm being moved to a HARP. What is a HARP? Should I do this? Is this better for me or isn't it better for me? And so it's important that providers really understand what it is that's happening to people. I should also say, and I'm sort of jumping ahead from Donna a little bit, is that HARP is adult, and I'll keep saying it over and over again, 21 and older, not kids, okay? So it's important. Now, what's the real difference between a HARP and the mainstream plan? Well, there are 3 or 4 that I want to highlight, although this chart lays out the differences. One is that we're having specialized staff requirements for the HARP. So the HARP has to have a psychiatric medical director. They have to have a psychiatric clinical director. They have to have a physical health medical director who could be part-time. And the purpose of that is that we want the leadership of this special needs plan, this HARP, the special needs plan embedded in a mainstream plan, like another line of business. We want them to have behavioral health expertise and a behavioral health focus because they're going to be serving people who are our high needs population. Additionally, the assumption is automatic that anyone in a HARP is eligible for a health home. All right, we recognize that we don't have sufficient health home capacity at this time, and we have to work to expand it. But the expectation is that as we build this out, everyone will get health home care management. There, again, the physical health, the behavioral health, and the pharmacy, the interaction with non-Medicaid social services for this population is often very high, and they really need to have that care coordination in place. So we're also working with the Medicaid managed care plans on an interim, what we're calling a bridge strategy or bridger strategy to figure out how we get from point A to point B, but the expectation is they're all health home eligible and that the health homes will do plans of care. Thirdly, anyone who's in a HARP will be eligible to be assessed for what we're calling home and community-based services or 1915I services. You might have heard them in a variety of ways. And these are similar to what you might have seen in a children's waiver, things which we've never really been able to do before. But these are recovery-oriented services, and Tom's going to walk us through the specific services in a minute. But it really range from things like supported employment, supported education, a crisis response, and mobile treatment. Okay? And again, it's an integrated benefit. So it's physical health, behavioral health, psychiatric leadership. At the very top, specialized expertise. All the plans are going to be expected to have crisis response capacity by phone, be trained in New York, and have connections to the community crisis response. So that's at a very high level, the HARP versus the qualified plans. We're also working on how to identify people who might not have a Medicaid history, but may be HARP eligible. They might have come out of a state psych center, and you want to get them right into a HARP health and recovery plan right away. And there may be people who are in jail. The methods for doing that will be through some sort of a clinical assessment that's being worked on at this point in time. All right, where we are in terms of project status before Tom goes over the different services is that we're going to be rolling out the health and recovery plan and the qualified behavioral health plan in April 1st, 2015 in New York City. 6 months later in the rest of the states. This is a delay of 3 months from what you might have seen before. And then the kids are still targeted for January 2016 at this point in time. All right, so I'm not going to go over what these state plan services are, but I'm going to ask Tom to talk us through the HARP. I'm just going to say a little bit about the designation process before he does that. First of all, how many of you are familiar with the HARP designation process? HCBS designation process. Very few of you. All right, this is important. Pay attention. Go to the OMH website, go to the OASIS website, and I don't know if it's on the DOH website, Linda, do you know? and the DOH website, look at a draft designation manual that was put out, I believe it was last week or just the week before. It lays out everything Tom's going to talk about these services and how you get designated. In order to deliver the services Tom is about to talk about, you must be designated by OMH or OASAS, okay? And we have a process laid out there. 3 state agencies will look at the submissions, all right, that come through, and there will be a designation process. You have to attest to meeting the requirements that are there, okay? We're really looking for folks who have the expertise to step up and be able to do this. But just stepping up and saying you're designated and getting designated doesn't mean you get any work. You have to then contract with a managed care plan, all right, because they will be referring any individual to the providers. There's a plan of care, and in order for somebody to provide the service that's in the person's plan of care for home and community-based services, that service provider must be in the managed care panel. They must have a contract with a Medicaid managed care company. So go back and look at the designation process, all right, and think about getting yourself designated. And we can answer more questions about this when we're done with the overall presentation.
Yeah, and I'm going to repeat some of what Gary said because it is very important. We are really looking for you as providers to get interested in these home and community-based services and get yourselves designated. HCBS have been around for a while, mainly in the managed long-term care plans. They've been services designed to help people who are at risk for institutionalization or institutionalized to return and remain in the community, so home and community-based services. One of the provisions in the Affordable Care Act allows for states to begin to offer those home and community-based services to other populations, and we're taking advantage of that provision, and we're introducing these HCBS into the Medicaid benefit package for these SMI serious SUD populations. So it's a major defining characteristic of our HARP plans. So what are they? And what Gary referenced, it's the HCBS Provider Manual. That's the official name of the document. It's posted. You can get to it through either the OMH website or through the DOH MRT website. I think it goes through MRT. Definitely look at that. It defines all the services, qualifications for providers, et cetera, and describes that designation process. Our goal is to make the designation process easy. We want as many providers as can to sign up and get designated so they can provide these services. It's going to be very critical to us. So what are they? Let's go through them quickly. Rehabilitation, so psychosocial rehabilitation, or CPST, Community Psychiatric Support and Treatment. A lot of you might say, well, we're doing this already for psychosocial rehab. We do social skills group, we do social cognition group therapy, we do wellness, self-management. Those are all forms of psychosocial rehabilitation. This is a little bit different. The key differences are these services can be delivered in the community, individually, face-to-face, or in groups within the community. Also, the qualifications are a little bit looser in terms of the individuals who are going to be able to deliver the services under supervision of more senior or licensed people. So really read through that manual, give you a sense of what these are all about. The idea here with the CPST and psychosocial rehabilitation is taking that next step from learning new skills, which people might learn in groups in the clinic setting, and applying them out in the real world. And that's it for those of you who really follow these evidence-based approaches. There are questions about which treatment interventions and which skills translate from the clinic out to the real world. And the idea here is to help facilitate that. So people might be involved in group therapy in your clinic, your outpatient program, and they can get these HCBS rehab services to help them practice those skills in the community in real-world environments. That's the idea there. Crisis services, we define 3 types of crisis services. We have in Hudson River and Central Region, there's a fair amount, or there's some respite services, Rose House, et cetera. There are some mobile crisis services. I was talking with May Lum. There's plans to try to really scale up and get more of these services going. If you think about our concerns about this excessive reliance on acute care, emergency room, inpatient care, and the goal to shift more services to community-based, having a real robust and effective crisis intervention program is going to be critical to that. We do want providers to pay special attention to intensive crisis intervention. By that, we mean, and again, it's defined in the manual, a crisis diversion program with real robust clinical staffing that can truly function as a diversion program. A setting where the people can come from emergency rooms, or maybe even police can transport people to these intensive crisis programs, and really do good work to avoid emergency room and inpatient care. Major goal for DSRIP, our Health Home Initiative. So any of you who are interested in developing those intensive crisis programs, we really support that. We have very little infrastructure for that anywhere in the state, and it's going to be a big priority area for us. You will get, in addition to that HCBS provider manual, we are going to issue guidance regarding codes, billing process for these 1959 services, so y'all can look at the specific services, you can look at what the reimbursement rates are going to be, do your business plans, see if you can make this stuff work. Habilitation services. Again, in the community, one-on-one or small group setting, domestic skills, using transportation, self-care, balancing a checkbook, cooking skills, shopping, that kind of stuff. Making that transition from learning skills in your clinic in a psychotherapeutic setting to applying them in real-world environments. Very critical step for us. Peer services at the bottom there. It's a smaller font. It's not on purpose. We're running out of space there. Everybody here knows New York State very much supports peer services. And this is a big step forward for us to get them paid for through this Medicaid benefit. You all have examples of where peers fit in. Peers are doing a lot of very effective work as bridgers, helping with those transitions from inpatient to community-based services. And again, given our numbers, given what we know about dropout rates and disengagement rates, having effective peer supports to help people make those transitions can be very, very helpful. Peers have been shown to be helpful in engaging the individuals that are lost to care, disengaged, or really not connected. So a lot of providers talk about, well, they're lost, they're out there. What can we do when we really can't get people in? Increasingly, we're going to come up with strategies and ways of identifying people who are disengaged, and peers can play a major role in helping make those connections and helping to get people engaged and activated towards their own care and well-being. And I went to a SAMHSA meeting last week where they talked about results from their primary behavioral health integration pilot programs around the country. And many providers around the country that participated in these SAMHSA programs used peers as navigators to help people receiving services in their behavioral health programs navigate their physical health concerns and needs. So another real important role that I wasn't so aware of, but so many of these providers really chose and effectively used peers to help with that behavioral health, physical health integration focus that we had. So again, we could talk about peers all morning. Let's move on. Support services, family supports and training. You do family therapy, you do family psychoeducation, you do a lot of work with families, but I'm sure many of you would say that so much of the work that your clinicians have done with families over the years has not been reimbursed. It's that problem solving, that managing acute crises, helping families navigate the community resources and get themselves up to speed with the resources, services that are out there. So that kind of work, again, in the community, at a person's home, with their parents, their family, their key support persons, helping get them organized and activated in the care of their loved ones. Employment services and educational services, if you really think about a recovery-oriented, person-centered approach to care, you ask people, what do you really want? People don't say, I want my hemoglobin A1C to go down. People say, I want to go back to work. I want to go back to school. So job and school, these kind of supports. And we do have, there's pre-voc work. In the manual, we define the 4 types of vocational programs that are currently have an evidence base for and are being used throughout the state. Pre-voc work, transitional employments, intensive supported and ongoing supported employment. They're very clearly defined. Most of you are aware of those models. We really want to scale them up. Same with educational support services. Someone says, I want to go to school. I want to go back to school. How do you navigate figuring out where to go to school, what to study, how to get enrolled, how to get the services you need, how to get supports through the programs in colleges, community colleges. So again, having a person that can go out in the community, work with people on putting together an educational plan and implementing that plan. That's what this is about. And the last thing, self-directed services. You know, if you take the whole notion of person-centered care, take it, you know, completely, totally seriously, at some point, you get to this idea of, well, can't people be responsible for actually some of the decisions regarding where the money for their care goes? And then there's a developing body of literature, research on patient activation or empowerment. And how do you really get someone? It's one thing to say to the providers, hey, you all got to get more active and going and engage people and work with them. The other side of the equation, what can we do to help our consumers get activated, excited, more motivated, and involved? Self-directed care is one very interesting way that the state is considering this. What if we could take maybe a couple $1,000s per year, put it into account, and say to an individual, this is your money, this is part of your premium, your health care money, it's in an account, and you're the person who's going to get to be able to decide how it's spent for your health and wellness. We're not going to give you a cash card, you can't go out and do what you want, but you're going to work with your treatment team to decide how you want to spend that money. You want acupuncture, exercise programs, transportation. What do you think? What do you think you would want to spend the money on that would best help support your health and wellness needs? And there's some good research out there indicating that this kind of approach can really be effective in terms of activating and motivating individuals. So you're going to see more. We're going to give a lot more guidance about how we will pilot those kinds of programs in the HCBS benefits package. So that's it in a nutshell.
Could you just mention, for peers to be able to bill Medicaid, they have to be certified, and how they can get certified with Donation Oasis?
Right. Bob mentioned for peers to bill the Medicaid, the peers as clinicians, I shouldn't say as clinicians, as peers are going to have to be certified, and both OMH and Oasis have developed and are rolling out certification programs for their respective peers. So, and you may have heard about that. If not, there's more information available, I think, through our websites, but we're definitely encouraging the peer programs and providers to ensure that those peers are certified.
So I just want to take a minute and reiterate how someone accesses these services. It's not just that a clinician says you should have peer support services or community treatment services. There actually has to be a plan of care. And that plan of care has to be done with the inner eye assessment. There'll be the mental health suite of the inner eye that will be rolled out statewide. And we're looking to have the health homes at this point to do that plan of care with the individual. Recognize that there's something called conflict-free case management. The federal government requires that we do care management in a conflict-free way, and we have to work with the federal government on how we actually implement that. But this plan of care gets done, and the service must be identified in the plan of care. Additionally, every one of these services has hours limits on them. So nobody can get more than whatever the hours limit is that's listed in the manual, and there'll be a total dollar cap on what a person can get in terms of all their home and community-based services. So you need to look at the manual. The dollar cap is not in there, but it will be coming out in the near future. The hours limits are in there. As Tom said, we're going to be putting out a billing guide. In fact, we'll be putting out a billing and coding manual for all of the different services. The one other thing before I turn it over to Rob Kent is that the one service that on my list that you should pay attention to, let me see if I can find it. I went too far, sorry. Let me see. State plan service. The last one, rehabilitation services for community residents, is not moving in to the benefit package in the first year. There are a lot of complexities about moving that service in, so we're going to be working on trying to figure out how to move community residents into the benefit package. It will be moved in at some point, probably in a year or so, but I don't want any confusion, so I just wanted to point that out to you. So, Rob, do you want to come on up? And Rob's going to talk a little bit about the legislative, contractual, and networking, contracting, and reimbursement requirements.
Is everyone still awake? No, just kidding. It's a lot of stuff to go over. So, as I said, this wasn't a straight carve-in. We've tried to build a number of protections into how we're doing this. So amongst them, and just to be clear, Hope and Alyssa went over the requirements now, the standards now as it relates to the current physical health care, managed care. What we're talking about will be built into the contracts. We think it's important that that be the case. So amongst them, network provisions. I mean, they talked about network adequacy. There's some additional pieces here. So I saw Kevin. Kevin's right there, so I'm going to pick on you. But so, for instance, if Kevin has 5 Fidelis members in one of his Medicaid programs, they have to offer Hope House a contract to be in their network. That's going to apply across the board first 24 months. The state operated, it's more mental health ambulatory services. We don't operate state operated ambulatory, but so the OMH ambulatory are got to be in the networks. Essential community providers, one critical piece for OASIS on that end, our opioid treatment programs, methadone programs, especially once you get outside the city of New York, are really regional providers. We're going to mandate that they be in every network. They have to be. I mean, they get into out-of-network issues and try to address, opioid treatment would be a complete disaster. So, and health homes are going to have to be in all the networks. We have to offer choice. It's a federal requirement. The plans will have to allow members to have a choice of at least 2 providers for each behavioral health specialty service. We have to have adequate capacity. I think we've talked about 50% is sort of the rule, but still working on that. Crisis services, they'll have to contract with them for 24/7 coverage. Plans contracting with our clinic providers, our government rates, our APG services will have to be paid. The HARPs will have to have an adequate network. The other piece on the clinic is that if you contract, and this makes sense probably even more so for OASIS providers, if you're contracting with Hope House's outpatient program, you're contracting with Hope House for all their services. It has to be the case, and it will be. And as I said, we will build these into the contracts. We think it's important. I'm a lawyer, so things that are in contract is better than people shook hands and had conversations and forget what they said to each other 2-3 years ago. So on the payment side, and this has been alluded to, there's the 2-year APG or government rate protections as we carve these services in. So the plans will have to pay that at a minimum. They could exceed that. We have great hope, but we know where that will probably end up. HARP capitation does not, the 1959 or the home and community-based services are not part of the capitation rate at the beginning. We in the plans need to build these 1959 provider networks, the home and community-based service networks. Just an aside on that for OASIS, we're doing a designation process because our view is a lot of providers who aren't necessarily licensed or certified by OASIS are providing these services. They're just not being reimbursed by Medicaid because it's not authorized yet. It will be. So we're taking a more expansive view of who could become home and community-based service providers, AIDS date treatment programs, alternative to incarceration programs. There's programs that don't work in the OASIS system operating our certified clinics but serve our members, and they go there willingly, so we can't ignore that fact as we're building this up. Medical loss ratio, the mainstream plan will have some type of medical loss ratio. I mean, there was a commitment by the MRT that all the money, if any, that was saved, and quite honestly, I hope we don't save a lot, I hope we spend it all. So just as an aside here, but If there is money saved, it's to be reinvested. That was a commitment from the MRT. It was a recommendation of the Behavioral Health Work Group. So we have to have some mechanism to track the behavioral health spend to make sure that we keep it in behavioral health. So there will be some type of behavioral health medical loss. There is not a medical loss for the physical health side. The HARPs will have an integrated medical loss ratio since it's a more integrated plan. We will build timely payment requirements. I mean, as you saw from Hope and Alyssa, there are requirements built in now with prompt pay. We've asked the plans to provide both web-based and phone 800 number. And we've required, we're trying to make it easy for claims to be submitted, and we're actually working on some other stuff to try to create some electronic capacity for all providers and plans to operate off of one system. Stay tuned on that. Web paper-based claiming. So the HARP medical loss ratio is 89%. Still working on the behavioral health medical loss ratio for the mainstream plans. Supporting access to treatment and recovery support. So, in addition, I just want to make one point with relation to the home and community-based services. The construct we're working on, they are offered most definitely to someone who's HARP eligible, who's been assessed to need them. There's no preclusion, and in fact, we will encourage the mainstream plans to buy those services in lieu of for all the members in their plan. And that's important for OASIS. Just to give some context, about 75% of those who get SUD services in the Medicaid world will not be HARP eligible. It's about 25% that will be, at least on the startup of how we do this. So we will be working with plans to make that available. We think it makes absolute sense given what they're trying to do. It's consistent with their mission. Couple important key pieces for OASIS. We are going to mandate our new Locator 3 tool be the tool that's used by both plans and providers. It'll be written into the contract. Pat Lincourt, who's my right hand on all of this, has actually been going all over the state of New York. We're field testing Locator 3.0 right now with plans and providers, Pat. Yes. It'll be ready to go. It's a web-based tool. It is nothing like Locator 2.0 that providers might be using. Excuse me, I'm getting over a cold, but it is something that we're going to mandate. And then OASIS on our state plan services. Right now, we're a clinic-based reimbursement model, meaning you can bill and be reimbursed for services provided within the four walls of your clinic. You can provide services outside the walls. You won't be reimbursed by Medicaid right now. We're going to move from that clinic approach to what's called a rehab approach, and that will allow you to provide services outside the four walls of the clinic. So these are more systemic changes that we're making at the same time as we're trying to create this new way of doing business with behavioral health benefits. All right. Training. We're doing the training here to try to assist you with the start. We're going to ask plans as well to train on billing, coding. I've said in the past at other types of meetings like this that if you all complained that there were too many of these things that we asked you attend versus not enough, then we succeeded. So I'll apologize for that on some level, and on some level I won't. It's an important thing. The more we talk about it, we think the better prepared you will be to handle that. We'll also ask them to talk about UM or UR or utilization management tools. Want to make a really clear point. The DOH folks, when they talked about there's no prior authorization for ER services, there's going to be no prior authorization for clinic services in the behavioral health world as we carve these benefits in. We will want plans to look at length of stay, and that's utilization management. We're still working on how often and when they could start to look at the length of stay in every setting. There will be prior authorization on inpatient stays. But again, we think it's important to be clear in the contracts on these two pieces. So we will spell that out in the contract. We'll make it clear to the plans. We'll make it clear to providers. On that end, I would offer to you, if you have ideas, thoughts, send them to Pat and I at Oasis, and Gary, Linda, on what's an appropriate point at which they should do utilization management for different levels of care. I can tell you, if you say never, that's a wonderful statement, won't be used. But so one other thing we are going to do is set up regional planning consortiums with our LGU partners. So we think it's critical that we set up this on-the-ground infrastructure. We'll work through the Conference of Local Mental Hygiene Directors, set up the consortiums. They'll have plans, providers, consumers, family members. Our view is, as we're trying to do everything we can to stay on top of how the benefits are managed, we need on-the-ground help. We need folks to be able to tell us when a problem's starting to percolate, if there is a problem. Finding out at the RPC level is going to be much more timely than if it's sent to Bob and I in Albany, it's probably 6 months down the road. It's too late, so we need to know sooner. We're still working through some of the mechanics and the financing of that, but we will absolutely use that approach. And I'm turning it to Donna for kids.
Hi, everybody. How are you doing? I think we're almost to a break, because kids are always last, like right before the break, so I think that means we're almost ready for break. So, I'm from the Office of Mental Health, but I'm presenting today on behalf of the Kids Leadership Team, which consists of myself and Laura Velez from OCFS, I think is out there somewhere. She's in the back. And Steve Hansen from Oasis and Linda Kelly from DOH. So we're all co-directing this kids planning process and have been doing so for the past, I don't know, two and a half years or something like that, a long time. So as Gary mentioned earlier, we're on a different timeline. At this point, we're scheduled to implement the kids' behavioral health stuff in January of 2016. So I'm only going to have 2 slides. So you're not going to hear quite the level of detail that you've been hearing on the adult side. But I do want to make the point, though, when Andy gets up here shortly and starts talking about the Managed Care Technical Assistance Center, everything that they're going to be doing with you guys and offering to you guys is absolutely relevant to the kids providers, even the kids-only providers that raised their hands earlier. I noticed that there was a number of you here today. So I don't want you to think that even though the kids implementation is later, and you're not getting the level of detail today, I don't want you to think that MCTAC is, I said it. Was I not supposed to say MCTAC? Sorry.
Say MCTAC. I have a joke to go with that later.
It's just easier to say MCTAC. So I don't want you to think that MCTAC is not going to be relevant to the kids providers, because they will be. A lot of what they're going to be doing is going to be, sort of generic readiness stuff that you have to understand about working with the MCOs, and that will be relevant to the kids providers just as much as to the adult providers. So thank you for being here, and I think you're going to really value what these guys have to offer. So I do just want to talk a little bit about the kids' design. Many of you have seen this pictorial before. I think Andy said it looked nice, so that's good. It's very pretty. You probably can't read it, but you'll be able to read it on the electronic copy that you get. But this is, we went back and forth for many hours on this pictorial. We really worked hard on it, and lots of people in this room and elsewhere contributed to the end result that you see here today. But I think one of the most important parts, before I kind of get into talking about the pieces of the model, and Gary mentioned it, and I'm grateful that he mentioned it, that there are no HARPs for children. Very early on in the planning process, we had much discussion and debate about whether we needed some sort of special needs plan for children or not, and ultimately we decided it wasn't a good fit. Kids in behavioral health care don't drive physical health care costs in the same way that adults do. And their functioning also tends to be much more fluid than adults. So those of you, I can see some nodding heads. So those of you who work with kids know what I'm talking about. Kids can cycle into times when they're functioning very, very poorly, but then they cycle back out, and that can happen fairly rapidly. And we didn't think it made sense, either programmatically or fiscally, to sort of direct kids into a special needs plan when it might not fit, even just a few months down the road. So the design is a mainstream plan design. So all of the benefits that you'll be hearing me talk just a little bit about will be contained within the mainstream plan. So the box that you see on the left-hand side kind of talks about that all kids, have physical health, and their pharmacy, and that's available in the mainstream plan now, will be available together with all of the existing state plan behavioral health services. And some new ones that I'll talk about shortly. And there'll also be a full array of home and community-based services. And those services, kids will need to meet eligibility to be able to access those services. But again, they're not going to be pigeonholed into a special needs plan. We're going to be using an instrument called the CANS that many of you are probably familiar with. And if they tip the scales on the CANS, they'll be eligible to access this array of services. And then they'll be assessed periodically, and if they're no longer in need of those services, then they won't get them anymore. And then the blue box underneath just talks about care management for all. So we do anticipate that a number of our high-end kids will be eligible for health homes and will get their care coordination through health homes. And then there'll be another mechanism for some care coordination for kids that are not eligible for health homes. And then I just want to talk a little bit about, so the bubbles on the right, the pretty little bubbles, the blue bubbles on the top indicate the entities that we will require the managed care organizations to contract with. So those are our providers. Substance abuse providers, our foster care providers, our mental health providers will all be, the plans will all be required to contract with them. And then on the bottom, the red bubbles that you see, so whenever we talk about kids, we acknowledge the fact that virtually all kids are multi-systems. At a bare minimum, a kid that you're dealing with is involved with school, right? At a minimum. But many, many of the kids that our providers treat are also involved with juvenile justice, right? Child welfare, any number of complicating factors are involved in our kids and their parents' lives. And so a point that we're beginning to drive home with the plans, and we've met a little bit with the plans, and we're going to be meeting more with them starting at the end of this month. But a point that we've been driving home to them is that you cannot adequately plan for the care of kids without taking into consideration these other community entities, even though those entities are not going to be in a contractual relationship with you, right? There's going to be no, contracting between schools and MCOs, but some sort of working relationship has to exist, and together we need to figure out how best to make that happen. But it's absolutely vital, we think, as kids providers, that we understand how to include those systems in these conversations about kids' care. So that's what those red bubbles are about on the bottom there. And oh boy, I have to figure out which button to push on this thing. The big button on the top. Okay, yay! All right, so I'm just going to talk just a little bit about the kids' proposed benefit package. So these. So we're proposing 6 new state plan services. So state plan services are the services that are available to kids who are Medicaid eligible and who meet medical necessity criteria. And so I'm not going to go into a ton of detail on this. I'll spare you that. So that'll be for another time in the future when we're much farther along. But I do want to note that a lot of these services already exist, but are currently not Medicaid fundable. With the exception, well, you know, we have a lot of family support across the state, and a little bit of it is funded through our existing home and community-based waiver programs. But not nearly enough. And so we're very enthusiastic about moving toward the future where we can offer much, much more in the way of family support, youth peer support, and these other services that are here that I think, again, it's for another day, but I think this array of services alone will help take some of the pressure off of our clinics, at least speaking from the mental health perspective, that I think our clinics bear the brunt of a lot of kids and families that need something, but it's not necessarily clinic treatment, and maybe it's one of these. So you'll be hearing more from the kids planning group about some readiness stuff that we're doing on our own, in which we'll talk about how can we reimagine sort of delivering kids services, new services, and in a different way. And then just a few words about the home and community-based services. So the Office of Mental Health already operates a home and community-based waiver for kids with serious emotional disturbance. And our friends at OCFS have actually 3 waivers in which they serve foster care children, foster care children with, that are medically fragile, foster care children with developmental disabilities, and foster care children that have serious emotional disturbance. And then our friends at DOH operate the care at home waiver. And so what we've done with this managed care transition planning is we've seen it as an opportunity to take those highly valued home and community-based services that are highly effective in terms of keeping kids at higher levels of care. We've taken those services and said, well, right now, they're really good, but they're siloed, right? So, you know, to access the OCFS waivers, you have to be in foster care, or, you know, you have to be seriously emotionally disturbed to access, you know, all the waiver or the respite and the family support and all the good services that are available through the OMH waiver. Why not break some of those barriers down? So essentially in the new design, what we'll be doing is sort of collapsing all those waivers and creating one big array of home and community-based services. And as I mentioned briefly earlier, kids will have to demonstrate that the eligibility via the CANs. But the other exciting part, besides kind of breaking down the walls of these things, is that currently in these waivers now, kids have to meet a level of care eligibility, meaning that they have to be really at immediate risk of institutional care, of hospitalization, residential care. And what we'll be able to do in this transition, as we've proposed it, is kids who aren't quite at that level of care, but demonstrate a level of need, will be able to access these services at a lower level of intensity. And I'm very excited about that. I think the whole kids team is very excited about it. You know, again, speaking from the OMH perspective, we've long recognized in the kids world that we're very, very good at delivering high-end services to kids. We have a solid inpatient base. We have good residential base with our RTFs. We have the home and community-based waiver for those kids who meet level of care. But once kids improve in those systems and then they're discharged, all they have available to them are the state plan services, which are good services, but often they're not enough. So kids sometimes then cycle in and out, right? They're discharged and they're doing okay for a while, and then things go downhill. Why? Because they don't have those support services like the skill building and the respite, and the family support and all that stuff. They don't have access to that anymore. So we're hoping with the level of need that kids can step down and have those same services available to them just at a lower intensity level. Or even better, maybe we can catch kids on the way up so we can prevent them from going into those higher levels to begin with. So that's just a really quick snapshot of what we're doing with the kids design. And I probably forgot something, but I think Andy's looking over my shoulder, so I'm going to hand it over to him. Okay? Thanks.
All right, how's everybody doing? Brains totally filled up at this point? Okay, so we're going to do a little flip and do questions now and then take a quick break. So I would ask people, as you have questions, to line up behind the 2 mics. There's one here and one here. We've got 2 roaming mics here for government folks if they want to come up here. I'd ask, government folks, if they're going to answer the questions that come up here. I just want a couple quick things. Please ask your questions from the mics, because we have, I believe, over 450 people online at this point, and they can only hear the actual stream from the microphone. So please do that as well. We're going to try to get through as many questions as possible, and then we'll take a quick break. So I'm going to start over here.
Yes, my name is John Coppola. I'm Executive Director for the New York Association of Alcoholism and Substance Abuse Providers. I just have a metaphor to start out with. It feels a little bit to me like a college-level physics textbook that we've been given and told to read, and we're going to have an exam after lunch today, right? So there's a ton of material, and I understand that this is a kickoff session, and it's going to be followed by a lot of technical assistance over time, which I think the field desperately needs. Having said that, I'm wondering to what extent, like earlier on in the presentation, when we started thinking about, okay, lots of providers are going to now be talking to lots of plans and lots of managed care organizations, to what extent is state government currently working with the plans on trying to organize that process in such a way that providers are not going to have to be looking at 15 different applications from 15 different companies? So to what extent can we standardize some of this? And then secondly, I'm very concerned that the implementation, once we kind of absorb the information, I'm very concerned about the actual application of the information. We've been doing technical assistance for about 2 years now, and still finding it difficult to get providers at the table working together to do the systems transformation that they're going to need to do. So at some point, this becomes about implementation, and I think that point is almost now. And so there's going to be a lot of us that we have to get. And so I want to just hear a little bit about what can be done to streamline this, what can be done to kind of create the cliff notes that we need to pass the exam after lunch.
So, John, that was a physics level question right now, and I'm not sure we can retain all the pieces of it. So I guess I'll just say a couple of things. I don't know, Rob, if you want to, but in terms of the list of providers, all the managed care plans received a list of providers they must contract with. So it isn't going to be guesswork. What we need to try and do is get that same information out to the providers so that they know exactly which plans need to contract with them. At least that will make it a little bit easier. We've also set the rates. So in the clinics, it's the APG rates. For the mental health services, for the non-clinic service, it's the government rates. So there's no negotiation required over rates. To the extent that a provider and plans want to come up with an alternative approach, they can submit that to us, but we are going to review it to make sure that it moves the transformation goals forward. We also have the whole technical assistance initiative that you're going to hear more about afterwards. In terms of getting providers to the table, I would hope it's in their interest to make the effort to do it, given that we're reaching out and pushing this information out to everybody as much as possible. You're not looking at going live outside of New York City until I think it's a year from now. So hopefully providers are going to take the time to get ready. I mean, it is a lot of information. This is being recorded so people can look at it again. There's the RFQ and the 1115, and we're just going to have to continue the dialogue.
Yeah, John, a couple, can you hear me? Yeah? Okay. Couple things. So we've engaged a little bit with the plans. They've expressed an interest in standardized template contracts, and we've reached back out and said it makes absolute sense. So we're trying to engage in that conversation to develop sort of across the board, same contract would be offered by, the different plans to the providers. So that's one piece. The other is that, as you know, we've reached out to the Health Plan Association. They did one meeting recently in New York City where we brought all the plans and the OASIS providers together. We're going to do more of that. I mean, we've offered already to the Health Plan Association from an OASIS perspective. We need to do a whole day just on methadone. I mean, it's not in anybody's plan, but it's 45,000 people, and, they need a lot of education on that. We've offered, we'll go sit in a room and talk with them until they're done asking questions. And then just generally, because as I pointed out just a little bit, some of what we're trying to do is more systemic. It's across the board. It isn't necessarily in the HARP itself, its overall clinic to rehab, locator, et cetera, we'd sit in a room a second day and answer all the questions from the plans that they might have until they're done. And I know you and other provider associations are reaching out and trying to do, as Jason Helgeson calls it, speed dating. So, I mean, I think the combination will help, but there is other stuff we're doing besides just these meetings.
I just, Gary and Rob gave you substance. I just a comment on following up on the college analogy. So some of the protections we put in place, you have been admitted. You've been admitted to college. You're going to be in the network if you serve 5 or more people. We're giving you some financial aid initially with government rates. We could provide some remedial help. But ultimately, you have to study for the test. You have to pass it or you're going to be flunked out.
All right, next question.
So, my name is Clyde Comstock from Hillside Family of Agencies and the Children's Health Home of upstate New York. Still a dream, but yet. I have a comment and a question. The first one is a comment. As we're looking at the complexity of organizations moving into this new system, we're doing it after 4 to 5 years of rate freezes. So I would say historically the agencies that are making the transition are probably at their weakest point, and now we're moving into major changes. Keeping the same rates for a couple of years after the transition helps protect you what you had, but it also keeps you at the low level you've been at for the past, in many cases, 4 to 5 years. So I think it just presents a huge level of difficulty for the service providers moving into the new system after having a lot of their organizational strength dismantled. And then a very concrete question. One of the slides referred to a disqualifying criteria as anybody who has a developmental disability. And at least in the kids system, there's a lot of people with developmental disabilities. It's slide 17 in the
Can I clarify that?
Sure.
First of all, we're talking adults 21 and older, but it's not anyone who has a developmental disability. It's anyone who is in the DISCO system or will be covered by their managed care excluded based upon code.
Okay.
So,
very good. That's not what it says here, and it worried me
Okay.
because I know on the kids side, we
Okay.
were thinking that people with developmental disabilities, if they're not in OPW, could actually be served by health homes.
right, so they would be served by Medicaid managed care the same way they are now in terms
Right.
of their array of physical health. We're not putting necessarily any new physical health services in, but they're not excluded if they're not in the OPW coding system
Great, thank you.
for adults.
My name is Harris Oberlander. I'm the CEO of Trinity Alliance. This is a question on the OASIS side. How do we know our rate in contract negotiations with the plans when the required staff configuration under the OASIS residential reorganization hasn't been promulgated and care level by facility/provider hasn't been designated?
So residential redesign is going to be phased in. So I'm sorry, I can't see you. So it's not going to necessarily start at the same time as we carve all the services in. It needs approvals from CMS. But by the time we do it, there will be rates. I mean, we will have the per diem rates established that will be paid for the new medical clinical services that are now being provided, and those will be the rates we would expect to be paid. And we could have another meeting just on residential redesign for OASIS. Suffice it to say, the other funding that's in the system doesn't disappear. This supplements that aspect. So by the time, especially by the time we move in the rest of the state, about a year from now, we'll have all of that established. But even having said that, we aren't going to mandate that providers automatically move at some magical date from the current way they do business to the redesign. We'll let them do that over a transition period, a year, 2 years, whatever it might take, and that'll be driven by their capacity to make it happen. So we're going to maintain the flexibility, but by the time we move to contracting, especially, well, anywhere, we'll have the rates established for the part that's going to be managed by Medicaid managed care. And the level of care too, I'm sorry, the tool our hope, by the way, on the tool is to have everybody who wants to use it using it by January 1. Yeah, we won't mandate it in January, but we certainly would strongly recommend you start using it, and we'd also recommend that to the plans. So you'll have a sense of what the tool does and how to use it, hopefully, far before we move into the beginning in New York City.
Hi, I'm Raphael. I'm from Hospitality House in Albany. I want to thank everybody for doing this presentation for us and giving us great information. First off, my question, I see a little bit of a contradiction, and I wanted to just get some clarification on it. With HARP, it's saying you need to have a psychiatrist on staff. I've also spent a lot of time contracting with health homes, with DISRP, where we've heard about partnerships. And so what I'm hearing is, the contradiction I'm hearing is competition versus partnerships. And what I'm confused about is, so if we're offering services if we're offering HARP, can we use the psychiatrist in the health home that we're contracted with?
So let me just clarify something. The psychiatric medical director is for the HARP, the Health and Recovery Plan, the managed care plan, must have the psychiatrist. It's not an imposition on a program where the requirement doesn't call for a psychiatrist now. We are not changing that. So I don't know if I'm either not understanding your question or you weren't understanding what I was saying.
I may not have been understanding what you were saying.
Yeah, so the psychiatrist is a requirement for the managed care plan. So they have psychiatric medical direction.
They have it on their staff.
Their staff, yes.
Okay, all right, thanks.
Just to comment on the other point you made about cooperation and network versus competition, it's a good question and it's interesting. In performing provider systems, nobody in the system gets the payments if the system doesn't produce the results, even to the point where New York State doesn't get the drawdown from the federal government if certain performing provider systems don't produce the results. So it's going to be an interesting world in that in order to do well and to survive, you have to be part of a network and you have to be a strong player in the network, but you're also competing with each other from the perspective of, are you the providers that are going to do quality? So think about it, say, like a baseball team. It's a team, and if they don't work together, they don't get the results, they don't win the game. But if somebody on the team is not performing well, they're dropped from the team.
Tony.
Hi. Thanks so much for this training. Bob Kent, you suggested that maybe you will be having too many of these. I don't think you'll ever have too many of these. So to the extent that all of you can do this, please do it as much as you can. I think there's a lot of questions and confusion out there. But I do have a very specific question. I also want to echo what the gentleman from Hillside said. And to that end, there's been some talk about, particularly on the DOH side at the very beginning of this, about, make sure you know what your costs are, make sure you have an adequate rate, make sure you negotiate the rate. But then we all do know that the rates are guaranteed for 2 years, that are protections for providers, and we also understand that any alternative rate methodologies have to be approved by DOH. My question is very specific and very concrete. Is it possible for a provider to negotiate a higher rate from the floor of the state guaranteed rate, and is that considered an alternative rate methodology that has to be approved by the Department of Health?
Yes.
Yes, it's an
Let
alternative.
me say something on rates, though. I'll speak from an OASIS perspective, and Bob, I'm sure, is going to want to say something from OMH. well, in Oasis, it's like the same 10 people who do everything. But so Pat Lincourt and Ileana did the APG system on the Oasis side. And our understanding is that our providers are breaking even or doing a little bit better. So I don't know if the question or the comment was driven elsewhere. And I do know that OMH is looking at their rates. They had other circumstances that related to everything being moved in. So I don't necessarily concede that the rates are inadequate on the Oasis side. And Bob, I don't know if you want to say something.
Can I just make one comment about that? Because we're basically budget-based, providers, particularly in the program type that I represent, providers have to break even. They really don't have a choice. So what they do is they just decrease, cut. And in particular, they've decreased administration down to the bone, and that's why they break even. But that doesn't mean the rates are adequate, and it certainly doesn't mean that they're in any position to make this leap to managed care in any kind of a robust way.
So I think there's a number of things out here at the same time. I think Rob was talking mainly about clinics. Oasis is looking at the clinics, OMH is looking at the clinics. What we've determined as a general statement from our analysis that a lot of the loss is on the commercial side, and we've been talking to the Department of Insurance about that. And I think we're going to get to the point where we're going to say to providers, you shouldn't be accepting business that's below your costs. And if that means the commercial the commercial plans have to go somewhere else, they have to go somewhere else. But we don't want to destabilize the public safety net by you taking on business below your costs. The COPS isn't there any longer. That's one point. Tony, I think most folks know Tony, but she represents the Association for Community Living, and I think she's talking about the Medicaid in community residences. Now, the first thing is that the OMH rehab option money in our residential programs isn't going to be in managed care initially. It's going to get phased in partly because it was so complicated. So they'll still be a fee-for-service player for a while. I think when you look at residential programs, day programs that do come into managed care, the plans aren't going to want to pay for long lengths of stay with no predictable outcome. They may offer additional dollars for very focused results for certain members that need intensive work. So I think both the plans and OMH will be interested in conversations for providers that provide specialty services that you may negotiate an enhanced reimbursement. But I just want to say the enhanced reimbursement from the plan's perspective is going to be for a value add. It's going to be for targeted individuals that you have convinced them you could make a difference in their life, and it's going to be time limited.
Hi, I'm Brian Cayley. I'm Vice President of Behavioral Health Services for St. John's Riverside Hospital in Yonkers. Had two questions. Number one is the criminal justice population. Many of us in the room do serve criminal justice patients. Is there anything contemplated with respect to those individuals maintaining their benefits when they're incarcerated upon discharge that differs with what's happening now, all under the heading of trying to keep them engaged in the system and get them back into a treatment setting as quickly as possible? And number two, are the plans planning to expand resources, particularly with respect to authorizations on a 7-day-a-week basis, which is something that's uneven now and really contributes to the workload, the callbacks, all of that? Is that going to be part and parcel of the model going forward? Thank you.
So, Brian, to your second question, as I said, on utilization management, we're going to build rules into the contract. So, no utilization management's not going to be in it, but something other than that. And I know some use 7, some do 10, some do 14. Input from the providers. And I've been talking to provider groups all the time and asking for input on what you think is appropriate based on who you're serving. And we'd like to build those into the contracts. In a perfect situation, we have the plans less focused on the front door, more focused on the outliers, and then what is that outlier? And separate, and it's really a separate conversation, but the insurance legislation that passed at the end of this last legislative session that the governor signed into law made some significant changes on the SUD side because of what we're dealing with the heroin opioid epidemic, which will impact some of that. But we need input. I mean, we want to write those rules. We don't want to leave it open-ended because we know what happens, particularly on the commercial side, and we don't want that to replicate. Ideally, we want to change it on the Medicaid side and have it change across the board, but maybe it starts from this side.
On the first question, there's populations that either lose Medicaid or aren't eligible for Medicaid in certain settings, and if you're in jail more than a brief period of time, your Medicaid's suspended. That affects your managed care eligibility. People in prison for longer times, and then also people in state hospitals, their state psychiatric centers, their institutions for mental disease. In a Medicaid environment where we're talking about care management for all and accountability, we're feeling that that's very essential for the populations we're talking about, whether it's a forensic population or somebody coming out of a state hospital. You don't get to a state hospital usually unless you're cared for in Article 28 setting and your symptoms aren't able to stabilize. So by definition, if you're coming out of a state hospital, you're high need. If you're coming out of a forensic setting, you may be high need and there's certain risks there. So we're talking with the health department about looking at that, and there's two parts of it. First, getting enrolled in Medicaid before you leave those settings. And then when you saw in the earlier presentation, they talked about somebody's in Medicaid, they have a month or so to choose a plan, and then they're in a plan. And there's some real technical challenges, but is it possible in the future, and we don't know the answer, this is a conversation just starting right now, is it possible to actually get somebody enrolled in a Medicaid managed care plan and get a care manager assigned before you actually come out of those settings? So again, there's a lot of challenges. It makes a lot of sense, and we're going to try to figure out how to do that.
And Bob, just to add to that, DOH does have a health home criminal justice work group that's been convening every month or two for the past year or so that's really examining all these issues. It's got people from docs on it, obviously DOH, some of the plans are represented, that are really trying to take apart all these issues related to that interfacing.
I would just urge that the counties participate in that also, because I think there's a lot of unevenness county by county in terms of how the current policy is implemented.
I think several key county people are, maybe some people in the room are, because there are several pilot projects that are being implemented at the county level across the state to try to tackle these communication issues.
Okay. But I think the point there is that the way the system is structured, the Medicaid really happens at the DSS level in the counties. So it is true that if we do come up with a way to engage and get people into care quicker from these settings, we'll have to be working with local government on how to do that.
Okay, thank you.
So we're going to go here and then come back to Andrew.
I'd like to speak to the revenue cycle impact. And somebody indicated that the contracts may be able to be standardized, but unless you tell me otherwise, I will assume that that does not include the provider and the billing manuals, in which case every payer could have different specific rules.
Okay, so what we're doing is we have draft codes, billing codes, for every combination of state plan service, and that draft manual hopefully is going to be out for public comment, not an official formal comment period, but some comment and feedback in the next couple of weeks. So we're looking to get that feedback from plans and providers, and then we're going to require that plans submit information to the state using those codes, and the most likely we're going to be requiring that all plans and providers use that to bill the services. So in the case of, say, a PROS service where there's a lot of different combinations of ways that you can bill, there'll be a set of CPT codes and modifiers that would be used to crosswalk back to every fee-for-service billing combination. But you will be required to bill using CPT codes and those modifiers when you're billing the managed care plans. Does that make sense?
Yes.
But those will be consistent across plans.
They will be consistent across plans. And the other piece is that for providers that don't have their own billing system at this point in time, we're working with a variety of the state agencies and others to see if we can jumpstart the creation of an HIT system that would allow billing at the local, particularly providers that have never billed Medicaid or Medicaid managed care. Now, in your case, I would guess that wouldn't be appropriate because you seem to be asking this question as if you have a billing system, but I assume there are others in the audience who never have billed Medicaid managed care, and this may be appropriate. So we'll see how fast we can get that out the door.
So my question also goes to the slide on training. You indicate that the plans will have to work with the providers they contract with to train them on their claims and billing procedures. But I would advocate that that certainly isn't enough to prepare the providers. At that point, we're going to be well behind the eight ball in ability to establish a high-quality Medicaid claiming office in agencies where that function, because of fee-for-service, both on the state EMedNY side and on the provider side, was less than efficient.
So I just want to be clear, and I'll go into this in a little more depth later. We are going to talk a little bit about kind of the structure for billing technical assistance that's going to go on. A couple of the things we are going to try to do is to condense across plans so that while you may have to get training from one specific plan to another, the global kind of piece of it is handled together so people don't have to be through 10 different plans with 10 different things. So I'm going to talk about a little bit more about that later in the afternoon.
Okay. I didn't introduce myself. I'm Andrea Smith. I'm the Executive Director of the New York State Coalition for Children's Mental Health Services. The comment and question that I really wanted to come up here and talk about is to emphasize a key difference, which you did a good job of emphasizing today, but on the kids' side, and the need for patient protections and contracting provisions because the children aren't going to be enrolled in a specialty plan. Their entire book of children's behavioral health services, including very complicated home and community-based waiver and really brand new state plan services, are going to be turned over to traditional managed care programs. And I know that it's difficult because I always advocate for provisions that just apply to the under 21 age group, but I will make no apology for continuing to ask for provisions, including one that Dr. Myers mentioned today, related to accepting all products so that a managed care comes to our specialty kids providers and says, sign this commercial rate, which is 90% below your cost, or I will not give you a Medicaid managed care contract. And unless we get protections for the children's specialty providers, there will now be no access for children's behavioral health services under this Medicaid managed care transformation.
So actually, I'm glad you raised the one point. Some providers have called us as they're being approached by managed care plans, and some managed care plans have something they call an all products contract, meaning we're approaching you because you're a Medicaid provider and we want you to sign up for that, but you need to also sign up for our commercial business or our FIDA business. And it may not even be clear what those rates are. Now, we have to understand this better. I think that there's actually some rules in the state that allow that at this point, and we want to understand it better. Andrea, actually, you and I were both at a Haney's conference last week, and you mentioned that advocates are starting to focus on that issue, so that may be something you want to discuss with your colleagues. But we don't want to have a situation where you've been basically a behavioral health Medicaid provider, you're engaging in a contract with a plan, they're signing you up for the business you do now, but they say that you have to sign up for other products. You may want to, but you should have hopefully some ability to decide that. And also, if you're signing on the dotted line, you should know beforehand what the payment rules are for that. So we are having that conversation with the health department.
And we're taking notes on this, so we'll add that to the list of things that we go back and get a more detailed answer on, and also make sure that we address that specific issue when the technical assistance stuff does stuff on contracts, and so people are aware of that when it comes out as well.
Michael Cole, Columbia County Department of Human Services. I wanted to thank you for this discussion. It's very informative, very necessary, and terrifying all at the same time. I am, I don't think, alone in being more accustomed to a fee-for-service culture and not accustomed to having to sell our product and am embracing the transition from volume to value. But I'm wondering if there's some assistance that the state can provide to the providers in standardizing data collection fields, data fields for value. If it's exclusively claims-based judgment of value, then that's one thing. But if we are to have a non-claims-based value, I would like to see some sort of standardization and advanced knowledge of that so we can prepare our health records.
In that, I'll try to answer that, or start anyway. So that's another long discussion about performance measurement and how we really are going to track the value. There's a lot of planning and discussion going on about it. DOH has the QAR program, and they post annual reports. The QAR is the Quality Assurance Reporting Requirements, so there are specific reporting requirements at the plan level that rely heavily on HEDIS measures, CMS measures, and that's been well established through DOH. And you should familiarize yourself with QAR and the measures that are being tracked, because what the state tracks for the plans are going to want to track for the providers. So that's a starting point, is QAR. Another area to look at is the BHO portal we talked about earlier this afternoon, where we piloted and tested these 30-some measures at the provider level. And again, for the behavioral health, for the mental health providers, you can actually see your provider-specific data. There's a lot of engagement measures there that go beyond the HEDIS and CMS endorsed measures that we're going to look at for performance measurement over time. So familiarize yourself with those, the portal. There's going to be a lot of talk about outcomes, but we're also going to need to talk about process measures. And then where you get into like preventive approaches, screening, implementing evidence-based practices, getting your staff trained on evidence-based practices. There'd be a whole discussion that we have to have over time about what key process measures we're going to track. And again, through forums like this, we'll flesh out what we need to do. But really, it's going to need a lot of work over time. You're right, a lot of work over time, developing and agreeing with everybody about what should be measured and where the bar should be set.
Just to add a little bit to that. Over time, we are going to be taking a modest amount of the premium and setting up for pay for performance, and then it'll be a conversation with all the stakeholders what it is we'll be looking at. Initially, I think we'll be looking at some basic things, but ultimately we do want to move to recovery outcomes. We'd like to incentivize employment and education and reduction in the contact with the criminal justice system, and that's how the plans will earn additional dollars or be able to share those, and their network will have to produce those. We're going to have these regional planning councils that we're going to be working through the counties, and we're hoping that there'll be able to be some standardization conversations there in terms of collecting certain information. We're going to be looking at the NRI document to collect what we're calling social outcomes, because the health department's department that manages the metrics for managed care have pretty high-level, sophisticated measures that are actually, there's some very good measures in there for behavioral health. There's not enough, and especially on the OASIS side, there's not enough, but the ones that are in there are good. But OMH and OASIS are going to be collecting additional information about a baseline for employment, a baseline for education, a baseline for homelessness, and then we'll be able to use those measures over time to see if they're improved. So it is government's responsibility, I think, here to make sure the focus isn't just on saving money or keeping people out of expensive settings, but on recovery and functional improvement. And we're going to be using the measures and the incentives that we could do through the contracts to do that.
Okay, so we're going to go here. We have time for 3 more questions, so I think that covers the people who are standing now. So.
Hi, I'm Pat Dowse. I'm the COO of the New York State Rehabilitation Association. We represent agencies who are cross-systems providers and focus primarily on voc rehab type services for individuals. So, of course, we're very excited to see the 1915 I waiver services that are listed that focus on making sure that people with psychiatric disabilities and substance use disorders are going to go back to work. And our governor finally put out something that calls calls for an attention to that matter, so I think the timing of all this is perfect. However, I know that Medicaid is supposed to be the payer of last resort, so I guess I'd like to ask OMH and OASAS what kind of work is being done with the VR system right now to talk about an MOU on your sister agency side at OPWDD. They're in conversation right now because they're adding new waiver services too to assist people with severe developmental disabilities to go back to work, and they're coordinating activities with the VR system, so we use both Medicaid and VR. Have we begun that? Do we need to talk about that together as advocates in regards to making sure that all the different systems are working together to support these people towards employment?
Medicaid is the last payer resort, and HCBS services come after state plan services. So we are looking at all this. We do have some rehab services in the state plan side now. The HCBS services we put together and defined, and the work we've done with our consultant, we feel are fundamentally different services, at least in the way they're delivered, to engage people in settings that have been traditionally difficult to engage them or to transfer learnings. Already in the definitions on the employment piece in our provider manual, we talk about, just like in Medicaid fee-for-service or state plan services, VR is the first payer. We've worked on that quite some time now, say through our PROS programs, where we have pretty clear guidance on what you could bill for and what you can't. So we could provide some guidance on that as we move forward with the HCBS services. But bottom line is, people can't not access this other benefit for people that are eligible for it.
Yeah, thanks, Pat. I mean, I'm building on what Bob's saying. I mean, you would definitely have that on our to-do list, because we understand and realize that folks have to go to Access VR first, supported employment after that, making sure that individuals who are eligible go to Access VR. So I understand that we need to continue those collaborations and MOUs.
Right, because you want to be able to keep a seamless system and not have the individual feel like they're being shuffled back and forth. That's the entire opportunity under managed care, is to allow the person to just do what they need to do without having systems interfere with the stop and go kinds of things.
Absolutely, and you remember years ago, we had intensive supported employment on the vested side when it was vested, and we had ongoing supported employment on the OPWDD side when it was OMR.
Yeah.
So we understand those concepts. So we'll make sure that we continue those collaborations.
And Pat, just to answer your question from the kids' perspective, so we're in the process of having conversations with CMS now, not on the managed care stuff, but on the renewal of our waiver.
Great.
So we're having conversations with them about how do we work with state ed and Access VR on the interface with the pre-voc and the supported employment, so as not to supersede anything that they're doing.
Providers have a 5-year contract.
Yeah.
At year 3, we're only into year 1. At year 3, which was just about when everything's going to roll out, would be the time when VR would reassess whether or not they're going to do similar kinds of contracting process. Just keep that in your mind as you're looking at this.
Yep, we'll be working together with you guys for sure. Thanks.
Tony, and then we'll come back for the last one over here.
Hi. I have a suggestion and a question. A lot of providers are very concerned and anxious about being able to bill a number of different plans. But there are third-party billers that will do that for you. So we're trying to put together a list of third-party billers to help people. It's not that easy, actually. I thought it would be easier than it is, but it's really not. But I did notice that New Jersey has a list of approved third-party billers on their website. And not to ask you to do more work, but if the state could figure that out and create a list, because the other thing I'm finding is I have no way of knowing about quality or competency or any of those things, whereas in New Jersey, they actually approve them. So just something for you guys to think about. And then my question is, as we introduce layers of payers, how does that impact the MLR?
That's something we're starting to look at. There's some providers that are getting ready for this, especially the bigger providers or the ones that have already come together in networks, having conversations with managed care plans about alternative payment models before we even start. We're going to have a meeting about that with some players in a couple of weeks. What we've said is that OMH, OASIS, DOH have to approve any alternative payment methodologies initially. And one thing we're concerned about, or if it's not done correctly, is if a plan and a provider system talk about shared savings. because they have targets, and if there's savings, the savings are shared with the plan and the provider. It's not necessarily a bad thing. It's a good incentive if you have really good metrics to drive that on. But what we don't want to have is that if providers are in a system where they could get, quote, shared savings, they don't start behaving like an insurance plan to get the shared savings. So this is very complicated. Now, the other thing we already realize is that the majority of the premium coming into the HARP is already in managed care plans. And when that money moves over, there's already multiple value-based purchasing models out there now. I was talking to an FQHC a couple of weeks ago, and they say that they, on the physical health side, already have almost like a physician care management monthly payment for primary care. They get a certain amount of payment for that, and if they need specialty services to refer them out. So we're already going to have all kinds of value-based models. Health First, big insurance provider in the city that's owned by the hospitals, has several value-based models with hospital systems. So as the behavioral health dollar comes in, we're going to have to look at it. But what we're saying is initially it's government rates for 2 years. If a plan and a provider wants to vary from that, they have to come to the state, and we have to look at it to make sure it will advance the objectives, and then we could approve that. And a provider has to understand that if we approve that and there's some risk involved, it's your risk. There's no safety net for that.
Just for clarification, I think my question was actually simpler than that, but thanks, that was good. The MLR...
Well, our world is scary too.
Yes, I know, I can imagine. We
Maybe
can only imagine. So my understanding is 89% has to go to services, so there's 11% left for administration overhead.
Let me go through it. So
my question, I guess, is, do you have the MCO, and then in 5 years you'll have a PPS, and then you have the providers. So what is the 89% have to go to services? Because it doesn't seem to me that there's enough for administration overhead for everybody in the other 11%.
There's 7.5% admin cap for the plans. In the first year, there's a 2% startup that goes to 1% in the second year and 0 in the third, and that 1 and 2% will go to a performance pool. And then there's a 1% gain sharing, which is, quote, profit, and that's how you, if you add all that up with the 89, you get to 100%. What we're saying is that any stepping down of the 89% has to be related to direct services. Now, the way you're paid now through Medicaid, once that payment is made to you, that payment includes all your costs. So we're not saying that when the money steps down to the provider, you can't cover your overhead. But what we're saying is 89% of the premium has to be paid to a provider for a direct service, and then that provider manages that money to operate their organization.
Thank you.
Right. And just to add something to that, any alternative arrangement that might exist, encounter data still needs to be submitted back to the state so we can actually see what's being delivered, because what we are concerned about is what Bob was talking about earlier, is that you could potentially put so many layers of administration on in one of these agreements that services don't really end up getting delivered. So by getting the encounter information, we'll be able to look at how that changes over time.
Okay. And then last question.
Yes. I'm going to make this quick. My name is Suzanne Tisney. I'm from the Lexington Center for Recovery, an Oasis outpatient provider. This is really a question specifically regarding where are the 18 to 20-year-olds going to fit in terms of managed care, particularly those right now who are admitted to methadone, who are admitted to day rehab. Are they going into the adult managed care, or where are they going?
So, I mean, we're talking 21 and above, so there'll still be fee for service until the 21 and under are carved in.
So an 18-year-old admitted
They'll still be kids, and I get what you're saying, but they're not part of what we're talking about right now. We have to account for that when we bring the 21 and under in 2016. But right now, they're not going to, it still would be a fee-for-service Medicaid payment.
Okay.
So we're going to take a quick break. We're going to, sorry, go ahead, Linda.
I was just going to offer to you one other thing, to the woman in the nice green shirt there. One other thing is that we are very Hi. Yeah, we're very interested in the transition age youth. And so, as we're working on the children's team, we're looking at those kids. What are we doing, making sure that appropriate discharge as they leave the children's system and go in? Are we identifying children who would be eligible for HARP? Are we identifying children who should be doing supported employment as children, as 15, 16, 17-year-olds, and then moving them on into the adult world? So we're very much involved with transition age youth and those issues. We don't want any kids falling through the cracks.
All right.
But thank you.
Oh, there we go. So we're going to take a quick break, a couple logistical things. If you're online, we're going to come back in 10 minutes. We're going to start at 5 after, plus or minus a minute or so. Go out, grab some coffee, run to the restroom. And there are 5 managed care plans that are tabling outside Fidelis, Beacon, WellCare, Capital District, and United Healthcare. Please exchange your information with them while you're out there. We'll get started in 10 minutes. Thank you so much.